Based on their skin tone, they start to suffer what I identified as PEPS, PEPS syndrome. And that is psychological, emotional, physical, and social well being trauma. What does that basically mean? It means that the individual starts to have all types of psychological issues where they may be depressed, they're stressed, they can be confused. Some even may experience self destructive thoughts, which is very unhealthy. And they also develop what I've identified as either a light skin color complex or a dark skin color complex. So when we're looking at PEP syndrome as a whole, when we look at the emotional trauma from colorism, that's fear. People can be unhappy, they're sad, they feel helpless. There's anger and frustration that sets in, and they feel a sense of humiliation and shame to have someone treat you differently solely based on the lightness or darkness of your skin tone leads that individual not only to psychological, but now we have emotional. Then we go into the physical trauma. What is the physical trauma in the PEP syndrome? It consists of one, the individual suffers from a lack of sleep. They can actually have, and Dr. Ronald Hall has noted this in his research, hypertension, which is high blood pressure, gastrointestinal problems. They begin to suffer from headaches, and they also have what I call appearance issues, meaning that in order for them, they believe in order to be accepted by society, by in order to get jobs, relationships, friendships, to be successful, they feel that they need to bleach or lighten their skin tone so that they will fit in and be more accepted. So that falls under the physical category of the PEP syndrome. Finally, under PEPs, we have the social. The social trauma is exclusion. That individual will be excluded from events, situations in the job, in the workplace, in society in general. They then may become withdrawn, antisocial, and it's a form of self isolation begins to creep in. It impacts people socially here in the United States, and I would believe also internationally with educational opportunities. There are biases that set in and other forms of discrimination. And they also feel that their voices are silenced. Here in the United States, one of the most disturbing issues involving colorism that leads to this PEP syndrome is the fact that it's blatantly joked about. You will have television shows where you will hear someone say to another individual, "Oh, you act so light skinned," meaning that that individual with the light skin, which is in closer proximity to whiteness, is believed to be acting more white as opposed to if they're Black, Indian, Asian, or Latino. We've also had instances here in the United States where they've held parties at colleges and universities. And in order for darker skinned women to enter the party, they'd have to pay a fee. Lighter skinned women were accepted to enter free. We've had disc jockeys on radio stations who would hold cruises each year, have games where they would pit light skinned people against darker skinned people. And they would make jokes about it. One of the biggest misconceptions with colorism here in the United States is the belief that only darker skinned people are impacted by colorism, and that's not true. People who with albinism, especially in South Africa and the African continent, and here in the States, and lighter skinned people are also treated disparately. How does that work? For example, within the Black community, the African American community in the United States, there is this belief that someone who identifies as Black but possesses very fair skin that is in close proximity to whiteness, that they're not deemed as being authentically Black. So they're treated disparately, they're treated differently. When it comes to a darker skinned person, you would have a lighter skinned person treat them disparately because of that dark skin tone. So, what happens when all of this occurs? This is where that PEP syndrome kicks in. When the PEP syndrome kicks in, the individuals, and let me use an example of a darker skinned young lady. She's dark skinned. Her entire life, from childhood into girlhood, her teenage years, and into college, she's treated differently, negatively, discriminated against because of her dark skin color. In the meantime, no one is ever looking at the psychological, emotional, physical, and social trauma that this young lady has been carrying with her from childhood to being an adult woman. And as she grows older, those that I will refer to as PEP syndrome, those PEP's issues begin to impact and affect her self-worth. She begins to have low self-esteem, low self-identity, self-respect, self-pride, and self-love. When those issues kick in, and this is my theory that I'm working on now in the form of a case study, that individual now believes I have no self-worth, I'm not good enough, I'm not enough. In order for me to find employment, to get married, have a boyfriend, to date, to be accepted socially in society, I need to change my skin color to be fair and light. And unfortunately, we have seen instances here in the United States, as well as internationally, where we've seen people have lightened their skin using bleaching creams and other products. My other theory in working with colorism and the PEP syndrome is that as a result of the PEP syndrome, the individual who has been victimized by colorism develops what I call, and let's say this is a dark skinned individual, they develop a dark skin inferiority complex, meaning that they place a high value on light skin and a low value on dark skin. That inferiority complex now has made this individual believe I need to bleach my skin. Here in the United States, the bleaching products and skin lightening products industry is in the billions of dollars. I am conducting a study now where I actually walked into a store in New Jersey and I found over 70 skin lightening products in the form of gels, creams, lotions, easily accessible. So I took pictures, which really annoyed the people in the store. But the point here is that this billion-dollar industry also causes health issues for women. Dr. Ronald Hall has noted how some of these skin lightening products have mercury in them, harmful chemicals that end up either in stillborn death, kidney problems, and other health issues. So what we need to do in addressing colorism worldwide, this isn't just the United States issue. We need to look at the trauma, the psychological, emotional, physical, and social trauma that colorism acts cause individuals. Because see, that is the danger. Because remember, that PEP's trauma is something that individuals carry with them throughout their lifetimes. And it does impact them. It impacts how they view themselves, their self-worth, whether or not they think they are actually good enough to be accepted. So globally, I am working on starting a movement called the Authentically Me movement through the Colorism Project, which I'm the founder. Working with Dr. Neha Mishra, Dr. Ronald E. Hall, and Dr. Lena Sharda, and we have the Colorism Institute. Our focus is going to send the global message that to be authentic in who you are, regardless of your skin tone, shade, or complexion. In the United States, there is an issue where they are denying DEI. It's an anti-DEI focus in a lot of states. The problem here is that colorism is not discussed. It's not talked about. It's ignored. It is an issue that we know it exists. We have laws here in the United States where if you discriminate against someone based on their skin color or the skin color of their spouse within the work environment, charges can get filed. But here's the problem. The bulk of employers are clueless as to what colorism is. Up until a few years ago, the justice system here, the court system, did not understand or did not believe that two people belonging to the same racial group could discriminate against each other based on the color, the lightness or darkness of their skin tone. So when we talk about intra-racial colorism, we're talking about, for example, we can have two people who are Indian treat each other differently based on the lightness or darkness of their skin tone. Interracial colorism, an example would be a white person, white American or white person in general, treating a Black or brown person, Asian, Latino, Indian, differently and discriminating against them because of the lightness or darkness of their skin tone. So we have intraracial colorism, which is within the race, and we have interracial, which means outside of that race. And it occurs a lot. There's so many equal employment opportunity cases here in the United States. The United States has established what's called the Equal Employment Opportunity Commission. And they're there. So when this discrimination occurs in the workplace and the individual knows that they've been discriminated against because of their skin color, they go and file a claim. If the investigation proves that there is colorism, skin color discrimination, the charge is filed, the employer is sued, and from that point on, they pay a financial penalty for that. And they're also required to implement training. My point here, everyone, is for the world to understand that colorism is not something we can just say, oh, it's a light skin issue, it's a dark skin issue, it's a medium skin tone issue. No, it's bigger than that because it causes psychological, emotional, physical, and social well-being trauma. And what happens, and this is why it's so important for all of us to understand this, as I noted earlier, people carry this trauma from childhood to adulthood. We have children, and I'll share this with you quickly. A little Black girl, 5 years old, in school. She was scratching her leg. And the teacher asked her, why are you scratching your leg? Does it itch? She told the teacher, no. The teacher asked her, does your leg hurt? No. So when she said, do you want some lotion for your leg? The little girl responded, no. So when the teacher said, well, then why are you continuing to scratch your leg? And the little girl was very dark. So she had scratched her leg to the point that the skin had turned ashy white. And her response was, because when I scratch it, it doesn't look black. That's psychological trauma, everyone. The child is suffering emotional trauma. The physical trauma and the overall well-being issues are really serious. I'll take it a step further. I was recently a professor in a university here in the United States. One of my students wrote that she's a dark-skinned girl, and her whole life, since she was a little girl, she wanted to change her skin color to be light-skinned because she was the darkest one in her family. And she felt that she was ugly because of the dark skin. Another example, a 10-year-old girl who was my neighbor's granddaughter years ago had a crush on a boy at school. And she was a very dark brown skinned little girl. And the little boy was very fair skinned. And he told her one day, I like you. And I think you're really cute, but I can't be your boyfriend because you stayed in the oven too long. Can you imagine that type of trauma for little girls? Then they go into high school and they don't get picked for dates or proms or parties because the bulk of the young men wanted to date lighter skinned women, lighter skinned girls or teenagers. Again, there's more trauma that they're dealing with. So what we need to do is have a campaign so that we can say to these young women and young men globally, there's nothing wrong with you having darker skin tone than somebody else. Whether you have a lighter skin tone, we need to warn them of the harm of bleaching and skin lightening products and say to young women, have them learn to develop a high level of self-esteem, self-respect, self-pride, self-identity. When we do this, in turn, we are now combating and stomping out the colorism issue. The media in the United States glorifies lighter skin. There was just a video on TikTok the other day where they noted the most beautiful Black women actresses in the United States, and they were all light skinned. There was not one woman with brown skin. So we have to move society to a point where everyone's skin tone and skin color is embraced, regardless of your race, your ethnicity, where you come from, where you live. It is important for us to understand that the psychological, emotional, physical, and social traumas of colorism can be devastating to such a degree that little girls turn into teenagers who turn into women who are walking around with PEPS issues their entire lives. And when they develop that dark skin inferiority complex, or it could be a light skin inferiority complex, that's all because of the psychological traumas they're suffering through. So we need to understand that we don't judge people based on how light or dark they are. Their worth is not valued by the lightness or darkness of their skin tone. And until we, and when I say we, the global community realizes this, we're going to continue on the same path where people are treated differently because they're dark, where people with albinism are treated negatively and discriminated against because they have albinism. So what is the bottom line? The bottom line is, I believe, in my research and the book that I'm writing now, we need a global campaign, authentically me, where people can feel that they can be their authentic selves, where they realize that the value and their self-worth is everything, and that your skin color is not a determining factor of whether you have any worth of value in any society on this planet. So with that, I would like to wrap it up and say that we need to warn people about skin bleaching. We need to focus more on diversity, equity, and inclusion globally, because colorism is a diversity issue. Skin color discrimination hurts, traumatizes, and as I noted to you earlier, leaves severe scars. So having said that, this concludes my presentation. Are there any questions?
For that impactful presentation. Your dedication to addressing colorism and its effects is commendable. Your work on the deep psychological and emotional impacts of colorism has shed important lights on these critical issues. If anyone has questions or would like to add it to the discussion, please feel free to ask. Okay, so we have one participant.
Why do some people choose skin bleaching, in your opinion?
I believe they choose the skin bleaching because from a psychological, from the PEP syndrome standpoint, they believe that if their skin is lighter, that they will be accepted more so in society as far as employment, of getting a job, finding a mate, a spouse, for marriage, have a larger social circle, and because they think they'll be deemed beautiful. Why? Because of this ideology that in order for someone to be deemed pretty and acceptable and nice looking and desirable, that their skin needs to be in closest proximity to whiteness. And it is that, unfortunately, that dog belief. So they think that, in my professional opinion and review, and based on my research, once they bleach their skin, I'm now one of you. I belong. You can't knock me. You can't reject me because now that I'm light, I'm going to be more desirable. I'm going to stand a better chance of getting a job or finding a husband or a wife. And unfortunately, that's why they do it. And I think it's also deeply rooted in the psyche with that psychological, emotional, physical, and social trauma. Because remember, they go through stages. It's the experience of colorism. That experience of colorism leads to the PEP syndrome. That PEP syndrome leads to them believing that I don't have any value or self-worth. Their self-esteem falls low. And then at that point, they develop these skin color complexes where they believe, well, if I'm lighter, I see how lighter skinned people are treated in society. And I want to be accepted and treated that way. So this is how that cycle works. So once they have that skin color complex, they're placing a higher value on light skin and a low value on dark skin. So if I bleach my skin lighter, where I already place that high value, I'm going to be more acceptable and beautiful and everything. We've seen commercials. I think it's Fair and Lovely, where they'll say the commercial basically says in so many words, do you want to be beautiful? Do you want to find a spouse? Then try this product. So when that PEP syndrome kicks in and those skin color complexes kick in, then they go to that skin bleaching.
Thank you.
Yes, you're welcome.
Anyone else who would like to ask any question?
I have a question.
Okay.
What role do cultural narrative play in shaping attitude towards skin color?
I'm sorry, can you repeat that?
Do cultural narratives play in shaping attitudes towards skin color?
The attitudes.
Yes.
Did you say changing the attitudes towards skin color?
Yes.
I think the only way we could change attitudes about skin color is, as I noted earlier, having this global campaign. My goal is to launch in 2025 a global campaign where we feature women and men of all different skin tones, light, medium, dark, in between skin tones, where we are embracing them and they're talking about how they feel about who they are and their skin color, where we send a loud message through videos, TikTok, Facebook, all social media, where we establish connections in every country And we blow this campaign up to such a degree that it's going to send a message to the world, the global arena, that regardless of how light or dark someone is, they have just as much value and worth as the next guy. The only way we can change the attitudes is by standing in numbers, by continuing like the conferences, like this conference, for example, this entire session. Each year we have the Ronald E. Hall Conference on Colorism. Dr. Lena Charter, who's here with us today, works with us in all of our projects. Our goal is to have a global connection where we have people from every country, continent on this planet working with us. And there's power in numbers. When you see a global group of individuals taking a stand against an issue, and we get traction, especially using social media, we believe that's going to change the attitudes in this country and internationally. It'll change, hopefully, your neighbor, or if a young lady likes a young man, it maybe make him see, well, you know what? I shouldn't judge Donna because of Donna's skin color. It's all about changing their beliefs and their perceptions. And that is the way we get to that attitude change. If we don't do this, 10, 15, 20 years from now, we're still going to be dealing with the same ugly issue.
Thank you.
You're welcome.
Ask.
Hi, I'm Professor Dr. Naila Riaz, and I'm really taken by your thought when you said that colorism is diversification. Yes, the philosophy behind colorism is beyond dermal sciences. And if this philosophy is attached with dermal sciences and the skin connects, that would be better to nourish the talent and to nurture the future tasks. Thank you very much. It was enlightening to know.
Thank you. You're welcome. And I also wanted to add for everyone that I think it's important also for dermatologists worldwide that if somebody walks into your office and other than them having maybe a spot from a blemish or maybe some trauma to their skin, and they are seeking a skin lightening product with a prescription, I think it's important for the dermal community to stop and conduct a thorough psychological, emotional, physical, and social well-being evaluation of that individual. Because if I walked into, let's say, Dr. Charter's office and said, Dr. Charter, I've had a blemish here, and the spot won't go away. I want it to be even to my skin tone. Dr. Charter should then say, wait a minute, Donna, let me evaluate Donna. And she should have a checklist, a form, something that'll let her do a what I call PEP syndrome evaluation to see, does Donna want this product because Donna wants to bleach her skin lighter? Or is Donna really concerned about that one little spot? And that one little spot is very visible. And I think in the dermal field, and I'm willing to work with anyone who's interested in doing this, so please feel free to reach out to me, that there needs to be a connection before these products, prescriptions are written. I think that in the dermal field, there needs to be a focus on that PEP's well-being of individuals as to why they want to be lighter. So those are just my thoughts.
Thank you, Dr. Donna Mary.
So we have another question.
So my question is that, what is your opinion about people who genuinely have the desire to have fairer skin? And what's the first step towards dealing with them and healing them?
I think the first thing is to understand What is the underlying reason why this individual desires lighter skin? And again, it takes me back to my PEP syndrome. Has there been psychological trauma from childhood through whatever age they are at that point? Is it emotional? Is it an emotional issue? Is it a social issue? Is it physical? Well, we know it's physical because they want the light skin. I think there needs to be a really deep discussion as to why this individual desires the light skin. In my past conversations with young women under the age of 18, they wanted light skin because they wanted a boy to like them, because they thought they were ugly, because they were dark. With the little girl where the boy told her, "You've been left in the oven too long," he was a very scared, fair-skinned little boy with curly, sandy brown hair. He was a cute little boy. But he wasn't cute because he was light-skinned. He was just a cute little boy. And he said to the little girl, "I like you. You have a nice personality, but you're too dark. You've been left in the oven too long." So it is my belief, and based on studies and research, especially by Dr. Charter, Dr. Hall, and Dr. Neha Mishra, is that there is a desire to be accepted, to be embraced, to feel a sense of belonging, to feel included and not excluded. There is this belief that with a darker skin tone, I'm not as pretty as Dr. Charter. I may not be able to get a boyfriend or a husband or a potential whatever job. There are studies here in the United States that have shown that lighter skinned children in school are treated better and they are not punished as severely as the darker skinned children. So again, I believe that the desire to have fairer skin is one, to compete, two, to be included, because a lot of people with darker skin tones historically are excluded. They're excluded from the mainstream. Another reason can also be that the media in this country, in the United States especially, they glorify lighter skin. We have several actresses who are Black. Let me give you a good example of the young lady, Dr. Shard, if you can remember her name. She is a ballerina, Misty Copeland. She was a brown-skinned Black girl and light brown skin. And she was getting into ballet. And she's done interviews where she noted she wasn't accepted because her skin was brown. And she was light. She wasn't very dark. So she said in a recent interview a few months ago that she found herself wearing the makeup of the white women who were ballerinas so that she could look like them. Because she believed that if she had that white skin, she would be more accepted as a ballerina. And a lot of this goes back to racism, the negative stereotypes, biases from historical roots. Historically, where here, especially in America, white people have white privilege. And that white skin color privilege enabled them to have better opportunities than someone who looked like me. I'm a brown skinned mixed race woman. I am Hispanic and I am Black mixed. So for people who looked like me in the United States, someone with fairer skin would be treated better and have more opportunities than I would have. So that individual says, I'm not accepted. I'm not getting dates. Guys don't look at me. I've had guys, and there have been things on social media. If you ever go to TikTok or even Twitter, well, now it's called X, where you see dark skinned girls being badgered, where they're told you're Black and ugly. Nobody wants you with your dark skin. I would never, and then a lot of young Black men in the United States have said this, and which is really terrible, that they don't want to have a dark-skinned girlfriend. because they don't want dark-skinned children. They don't want to have children with bad hair, as they call it, meaning kinky hair. They want their children to grow up having it easier in life because of the belief and the obvious that's here in this country and worldwide. The lighter your skin tone, the more favor you are given, the more opportunities for you. So imagine a little girl growing up into a teenager, and she's seen this her entire life. She's had family members say to her, don't go in the sun because you're too dark. There's an old saying in the United States, don't drink coffee or your skin will get dark. My grandmother, who was Hispanic, always told us that don't drink coffee. If you drink coffee, you're going to get dark. Don't date a dark-skinned man because think of your children. If you fall in love with a man who's dark-skinned, your children may come out dark. I grew up hearing this. It didn't impact me. That's what made me want to dig into colorism. But imagine a little girl whose family members of the community, her peers at school, in the work environment, social circles are always telling her, you're dark. You're not the pretty one. You don't have the favor. You're not a pretty girl. Your life is going to be difficult because you're dark. Then we look at caste systems and how they work. So how do we deal with someone who says, I want to be light-skinned? You sit down and you have a heart-to-heart with them and you show them. And this is where the empathy and the compassion, and this is what humanity is all about. You say to them, you are beautiful. There's nothing wrong with your skin color. Now, that would require, and I'm not a psychologist, so I would try and offer what I could. But if I saw the individual, like the young ladies I have dealt with, I'd give them referrals to go talk to someone, whether it's psychoanalysis or a therapist, to talk it out. Why do you feel the need to be light-skinned? What do you think having lighter skin will do? How will it enhance your life? Will it make you more accepted member, and I say this in quotes, of society? But the bulk of the time, and if you ever get a chance, look on social media. I urge all of you, go through Twitter, which is now X. Look at TikTok. Look at some of the nasty, negative comments that darker skinned women have to deal with. Look at how there was an issue years ago where they had this thing called Team Light Skin and Team Dark Skin on Twitter, where darker skinned girls were treated terribly because they were dark.
You, ma'am.
Excuse me. And it didn't matter if they were pretty and darker skinned. What mattered is that they were dark. And because of that dark skin color, they were treated negatively. So you have to talk to them. You have to sit down and find the root issue as to why they want to be light. You also have to say to them and alert them to the dangers of these skin lightening products. Dr. Ronald E. Hall, has thoroughly documented how these skin bleaching products can cause kidney damage, how there's mercury in some of the products that they are making in Ghana using compounds and chemicals, and how they resulted in stillbirths for babies and cause severe health issues for the mother. So we need to have these conversations. Another thing I'd like to say, and then I'll end this, I'll stop, I don't want to use up all the time, is to the campaign, this Authentically Me campaign, global campaign, where we are glorifying all skin tones, where we have ads, we have commercials, we have videos, we have seminars and discussions where we have people talking about the beauty of the various hues of skin tones in this country. It's not going to stop until we, the world, members of society, push back on this dogged belief that the lighter you are, the better you are. We have to push back and reject and really go after employers and educational institutions that glorify and treat lighter skinned students better than darker skinned students. A final note is that people have biases, and some of those biases are unconscious. Some people don't even realize colorism can be an unconscious issue. It can be unconscious and it can occur consciously. It can be intentional and unintentional. What we need to work on to deal with this PEP syndrome is to say, let's really have training in the workplace. Let's have training for teachers, professors, medical doctors. In the United States, there are issues where darker skinned people are deemed to be able to deal with more pain than someone who's lighter skinned. A darker skinned person going to the doctor, saying to the doctor, "Oh my gosh, I have severe back pain. I can barely walk. I'm excruciating pain." Despite the diagnostic tests, the x-rays and MRI, showing that this person does have a herniated disc or nerve damage, their pain threshold is going to be deemed, well, you know what? She can deal with the pain. But if a lighter skinned person would go to that same doctor and say, "Doctor, my back pain, oh my gosh, I can't take it. I'm dying. I can't walk." That lighter skinned person is going to be given a prescription for pain medication, referred to physical therapy. They're going to be given a referral to see another doctor. But there's this belief that darker skin tones can endure more pain. Years ago, historically, there was a doctor whose name I cannot think of, who would perform experiments on Black enslaved women with no anesthesia. They were gynecological experiments where he would actually do surgery on this woman while she was awake. And he did it several times. And there was a belief that because of her dark skin tone and her race, that her pain threshold was not that of a woman who was white or of a lighter skin tone. And you can research this. This is what happens. So we have to change how people think, how people perceive, how people gauge others. My pain, Dr. Sharda can have a bad toothache. I can have a bad toothache. How can you say that Dr. Sharda's toothache pain is much worse than mine when you're looking at an x-ray and that x-ray shows we both have an infection in the root of the tooth, severe infection? But the doctor could say, "I'm going to give Dr. Sharda pain pills." And he could say to me, "Donna Maria, you're going to be okay. We're just going to give you antibiotics. And you can just take Tylenol for the pain." Do you see the discrimination and the difference? Because of my skin color, I was treated disparately. I was treated differently. So we have to remove the stigma that darker skin can endure more pain. They can be treated any which way they want. We want to treat them. They don't have as much value or worth as a lighter skinned person. We have to go to the medical community. We have to go to our educational institutions, our employment sectors, financial sectors. Here in the United States, there have been issues where darker skinned people are not given mortgages because they're dark. They're rejected for automobile loans, and they could have better credit than a white person or someone with lighter skin tone. So how do we do this? We have to look and include colorism and skin color discrimination in our diversity, equity, and inclusion initiatives. Because here in the United States, it's very rare that you're finding the inclusion of skin color discrimination or colorism in any DEI literature. And my goal is to break that mold, to stop that. to write articles, write books, do presentations where I'm saying to the world, stop and listen. And that's what the Authentically Me campaign is about. Stop and listen. Colorism is a diversity issue. Diversity is about embracing people, embracing differences. Equity is making sure we're leveling the playing board so that everybody has an opportunity to be successful or they're treated fairly. When they go to the doctor, when we talk about inclusion, my pain, you're taking my pain as serious as you're taking Dr. Sharda's pain. Until we change our mindsets and the way we look at people of different skin tones, if we don't stop it, it's going to continue. So if you see it in a college classroom, if you see it in the medical field, if you see it in middle school, elementary school, in the workplace, say something, speak on it. If you have lighter skin and you see someone with darker skin tones being treated disparately because they're dark, say something, stand for them. Because a lot of times, a lot of people with darker skin tones are afraid to speak up when they're not being treated fairly. We have to change the mindset of all members of society if we're going to eradicate colorism. If we're going to convince people that the color that you are born, your skin tone, there's nothing wrong with you. You're just as welcomed here as someone who's lighter, darker, or medium skin tone. But it's all about changing the mindset. It's all about training your faculty, training your staff at the colleges and universities. I'm, as I noted earlier, a mixed race woman. I've been treated differently, negatively, because my skin color. So can you imagine? I'm an accomplished woman. I have a doctorate degree. I own several nonprofits, talk radio show. I own a publishing company, the Colorism Project, the Colorism Institute. I'm the founder of the Ronald E. Hall Conference on Colorism. But guess what? I still have to deal with issues. It doesn't matter how accomplished I am. It doesn't matter that I'm Dr. Culprit. And until we as members of society stop judging people on the color of their skin and judge them based on the content of their character, how are they presenting? What are their characteristics like? This should mean nothing when you're looking at whether you think I'm good enough. And if we don't stop doing it, as Dr. Hall noted, in a couple of years, we're going to have, it's going to get uglier. And I just couldn't imagine it being any uglier than what it is. So we have to change the mindsets. There has to be training. And if we don't start conducting training, I have seen colorism in the classroom. I've seen professors treat lighter skinned students better than darker skinned students. I've seen it. My students have told me. I've seen it in corporate America, where I was a VP in corporate America years ago and I walked away because of the colorism issues, the racism issues. Colorism and racism are cousins. They're related.
Thank you, Dr. Donna Maria, for sharing your valuable expertise with us. It was such an important discussion. Thank you.
Thank you.
You're welcome. It's now my pleasure to introduce Dr. Lina Sarda, joining us from the US, a dynamic speaker, consultant, and author with extensive expertise in education, training, and organizational development. Dr. Sarda is an accomplished public speaker and facilitator with advanced proficiency in equity, diversity, and inclusion. She has worked with organizations like Public Health Canada, the City of Hamilton, and Mohawk College, and is a member of the Institute for the Study of Colorism and the Anti-Oppressive Education Committee at MC Master University. Your insights on colorism are invaluable, and we are grateful for your time and expertise. Today, Dr. Sarda will be speaking on the overlooked epidemic, colorism's toll on women's psychological health. Dr. Sarda, we are excited to hear your insights. Dr. Sarda, can you hear us clearly?
I can. Good morning. Can you hear me clearly as well?
We are unable to hear you, sorry.
Okay, hold on one moment.
Yes, now we can hear you. You can start
Can
your
you hear me
presentation.
now?
You can start your presentation. You can start your presentation now, ma'am. Please welcome Dr. Leena Sarda.
Can
Are
you
you
hear me
able
now?
to listen us?
Yeah, I can hear you. Can you hear me?
You can start your presentation, please.
Okay, you can hear me, right?
Yes.
I'm just going to share my presentation.
Dr. Leena, please start your presentation.
Can you see my screen, my presentation?
Yes, it's visible.
Okay, thank you very much. So good morning, everybody. It's truly a pleasure to be here with you all today. And there have been some amazing presentations and speakers this morning. This is a topic that's very close to my heart, and hearing Dr. Culbreth's words is always an inspiration. This topic resonates deeply with me because it impacts so many, yet it isn't often spoken about in terms of its toll on our psychological health. And I know that Dr. Culbreth has talked a little bit about that, so I'm going to pick up where she left off. So I've dedicated the last 13 years or so of my life to researching this topic in various capacities. It's been the predominant focus of my research. I also examined the relationship between skin tone and self-esteem amongst South Asian women from a multi-generational perspective. This is actually the first study done to date looking at this issue across the family unit from a multi-generational perspective. We know that colorism is a complex societal challenge that's persisted across cultures in the globe for many, many years. It's infiltrated our interactions, our perceptions on a daily basis. And today I want to delve into an issue that looks at the intersection of dermatology, psychology, as well as social justice. This phenomenon is deeply, ingrained into our psyches and our just everyday things that we do and see, and it affects not only how individuals perceive themselves and others, but also significantly impacts their overall health and well-being. Give me a moment. Sorry, I'm having some trouble with the slides. I'm not sure what you're able to see. Sorry, give me a moment here.
Is there any technical issue there?
Yeah, my slides are not seeming to
You can take
advance.
your time.
Has it moved to the next slide now, or is it still on the intro slide? Can you tell me what you see?
Yes, we can see your slides.
Can you tell me which slide you see? Is it still my introduction slide or is it my next slide?
As a speaking notes.
Okay, so it looks like it's not going to work. So I'm going to stop sharing. I'm just going to go through my presentation just like that.
Okay.
So I had some ads I wanted to share with you. Unfortunately, I'm not able to show them, but they were just some fair and lovely ads that I wanted to put across. You've probably seen a lot of them through your everyday interactions, driving and seeing them on billboards, in advertisements, in magazines, on TV. And we know across South Asia, Fair and Lovely is very, very common. It's been rebranded lately as Glow and Lovely. Instead of reworking the formula of the skin lightening cream into another product or moving these kinds of products from stores, the company has done nothing. It just changed one word. So now it's called Glow and Lovely. So this performative move from the company needs to be called out, and it needs to be taken. No, it's not really a tangible action. It's not something that will, rectify or change the course of why it's continuing to be sold over counters in pharmacies or at the chemist. So the time, money, and effort that they've poured into convincing people that light skin is the only acceptable standard of beauty. A word change does nothing to address the deep-seated impacts of colorism that Dr. Culbreth was talking about earlier. Using new words like glowing, brightening, and spot reducing are just marketing strategies for saying white or light skin. They're a poor attempt at putting a veneer of acceptability on an outdated and problematic product. Across South Asia and the diaspora, we know that skin lightening creams are hugely popular, have received endorsements, across Bollywood and Lollywood with actors such as Shah Rukh Khan. However, despite best advertising efforts, the fact remains that these creams are dangerous. And we've heard about that from Dr. Ronald Hall, as well as Dr. Culbreth, on the kinds of chemicals that exist in here, right? Corticozoids, mercury, hydroquinone. These creams and the advertisements that go along with them reinforce the view that dark skin is undesirable, which actively contributes to the harmful obsession with skin lightening, and that it just grips so many communities across the globe. So I'm focusing more on psychological health, and this is what I talked about. It's one of those overlooked areas. It stems from societal pressure to conform to certain beauty standards, right, that can really exacerbate our skin condition. So psychological health is actually looked at as the sum of how we think, how we feel, relate, and exist in our day-to-day lives. Our thoughts, our perceptions, emotions, motivations, interpersonal relationships, and behaviors are actually all a product of our experiences and the skills that we've developed to meet life's challenges. So this includes a holistic sort of look at it. It includes mental, emotional, social, and spiritual dimensions. Possessing strength and resiliency in these dimensions can help us maintain an overall positive well-being and can really help us, face difficult situations in life. Most experts identify several basic elements that are sort of, they say, if you're of positive psychological health, these are the kinds of behaviors that people will regularly display. They will feel good about themselves. They feel comfortable with other people, respect others, and have compassion. They are also self-compassionate. So it's important to be compassionate towards others, but also towards ourselves. They can control their tension and anxiety. They meet the demands of life. They can curb their hate and guilt. They maintain a positive outlook on life. They value diversity, and they appreciate and respect the world around them. So in some, psychologically healthy people possess all four of those areas I was talking about, and resilient individuals have the ability to overcome challenges. Even if small things come up in life, they're still able to move forward and look at things in a positive way, and usually respond to challenges and frustrations in an appropriate, healthy way. And then I had, unfortunately, I wish you could see my slides, but it's not working. But I want to talk a little bit about intersectionality. So it's important to look at the issue of colorism through the lens of intersectionality, because it really highlights how different aspects of who we are in our identity. So let's think about things like gender, maybe race, maybe age, all these other things. I always say, I like to use my hands, right? These are all the different parts of us. They intersect. And these intersecting identity markers can really compound the discrimination that individuals who hold multiple marginalized identities can experience. So this compounding discrimination can have a negative effect on a person's health, physical, mental, or emotional, and factors such as colorist attitudes, for example, in society, across the media, maybe even in someone's family, can have lasting negative effects. Growing up and being surrounded by colorist messages through all the areas that I just mentioned really push the idea that fair skin is attractive, but in turn, this can really negatively impact one's sense of self-esteem, their overall identity and level of self-esteem, and that this can carry on into adulthood, as Dr. Culbreth was talking about earlier. So family, culture, and media play a pivotal role in race socialization and in promoting a sense of racial, ethnic, and cultural pride in children. Messages related to racial and or ethnic pride are passed down from parents to youth and are considered to be what we call protective measures. These are to promote positive racial identity as well as to prepare children to deal with things like racism and colorism as they get older. So for women, looking at psychological health and self-esteem issues, this is across the genders, but women are more so impacted by beauty norms across the globe. So the implications of colorism are even more so pronounced. We see societal beauty standards often placed. There's a premium on light skin, right? We call it social capital. And that's according to Dr. Margaret Hunter. So the idea is that light skin has so much value attached to it. It's almost like money. So we say social capital. And it gives you all the things that was talked about. You know, it could give you a good job, it could give you a good life partner, it can even give you better treatment in your job, making more money, better access to opportunities, education, many, many things that the research has shown us, and it's been presented to you this morning. And women have faced increased pressure to conform to these types of standards, and this can impact the self-esteem and mental health so much. Facing constant scrutiny can lead to things like anxiety and stress, depression, body dissatisfaction, so more so body dysmorphic disorder, which I'll be talking about in a moment, low self-esteem, internalized racism and colorism, social withdrawal. So studies across the globe have shown that people of color, particularly those with darker skin, receive less adequate medical attention and face biases in clinical settings. So some of the detrimental effects start off by talking, I won't talk about anxiety and depression too much because I think Dr. Colbreth talked quite a bit about it, but individuals who experience colorism are more likely to suffer from symptoms of anxiety and depression than those who do not. So for example, dark-skinned individuals may feel more isolated and excluded from social settings. This is going to lead to feelings of, sadness, loneliness, isolation, and they could also experience, if they experience any type of scrutiny, maybe teasing, bias, any type of prejudice or covert or overt discrimination related to the color of their skin, they can suffer from deeper levels of anxiety and depression, like Dr. Colbreth was talking about, that trauma that stays with you, for life. It's not something you can just easily shake off. The relationship is further exacerbated by direct experiences of discrimination and exclusion. So, for example, in the study that I did, the women that I spoke to and met with darker skin tones reported feeling so much deep sadness and unease caused by anxiety due to societal pressures and the stigma that they felt related to, different sources coming at them to put pressure on them to lighten their skin. There's a great deal of literature that shows in African American populations, there's a strong correlation with depression and internalized racism and colorism, really highlighting how societal biases can lead to pervasive feelings of inadequacy as well as hopelessness. And then if we look at, I was talking about body dysmorphic disorder. So we know body image and self-esteem go hand in hand, right? Self-esteem starts in the mind, not in the mirror. It can change the ways you understand and value yourself and your self-worth. Healthy body image and self-esteem are a big part of well-being. So body image and self-esteem, they're going to directly influence each other. So your thoughts, your feelings, your behaviors. If you don't like your body or a part of your body, it's really hard to feel good about your entire self. But the reverse is also true. If you don't value yourself, it's hard to notice the good things and give your body the actual respect that it deserves. Skin tone is a prevailing variable that dictates body image and is a measure of beauty across the globe, unfortunately. Colorism can contribute to mental health issues, as I've just chatted about. But body dysmorphic disorder is a common, often severe, complex disorder characterized by excessive concern about one or more perceived, and I'm going to highlight that word, perceived, because it's what we think. Doesn't mean it's true, defects in one's physical appearance. So individuals with body dysmorphic disorder believe that they look maybe abnormal or not beautiful, or for example, they think they're ugly or deformed, whereas to others, they don't see these things. They think the person is, quote unquote, normal looking. Individuals with body dysmorphic disorder suffer from severe emotional distress that can be overwhelming and cause difficulties in their daily functioning. So for example, they can have trouble focusing or concentrating, being around other people, dating, socializing, doing their schoolwork. The difficulties can contribute to diminished quality of life and may be severe. Sometimes in extreme cases, we can see psychiatric hospitalization and suicide. And they're always trying to do things to fix their perceived flaw. So you could see the behaviors you might see, and this is important to note in your practice when Dr. Colbreth was saying, do that deeper dive, do that psychological assessment when someone's coming into you and seeing you to say they want to lighten their skin. Is there excessive mirror checking? Is there excessive comparison with the appearance of others? Maybe excessive and or self-injurious procedures to lighten skin, like she gave the example of the little girl scratching the skin, wearing clothing or accessories to camouflage what they perceive as the flawed part of their body, adopting elaborate makeup, beauty routines, the white powder on the face, doctor shopping for cosmetic treatments, so trying to find that doctor that's going to help them lighten their skin, frequent clothes changing, to maybe a color that they feel looks better against their skin tone, taking lots of selfies on their cell phone to check their appearance and using different type of lighting to make their complexion look lighter. A lot of the literature on this topic looks at physical beauty, and there are some studies that look at this in South Asian populations, and across the board, skin tone and body image disturbance are what they look at them. It shows that majority of women respond less favorably to aspects of their body, and in South Asian communities, skin tone seems to be huge. Low self-esteem and low self-worth. So colorism can foster a negative sense of self and really undermine our self-confidence, particularly among individuals with darker skin tones who may internalize these feelings of inferiority and inadequacy. And individuals who experience colorism often subjected to negative comments about their skin tone, which can significantly affect their sense of self, right? And their sense of self-worth. Research shows that in communities where lighter skin is idealized, darker skin individuals report lower levels of self-esteem. That's perceived and actual discrimination. And Dr. Culbreth did talk about internalized oppression. So I talk about that as well in colorism. So it refers to the acceptance and internalization of negative societal beliefs and stereotypes about one's own racial or skin tone group, leading to feelings of inferiority, self-doubt, just not feeling good about oneself. And individuals who experience colorism may internalize the belief that their skin tone is ugly, undesirable, leading to self-hatred and a negative self-image. Dark-skinned women who internalize colorism will perceive themselves as unattractive or less attractive than others. This distinction is very important. So not every woman who internalizes colorism will see herself as unattractive, but she may rate her beauty below others with more Eurocentric features. So what we mean by Eurocentric features, maybe lighter color hair, like blonde hair, white skin, light eyes, and individuals may exhibit certain behaviors, such as avoiding the sun, wearing certain colors against their skin tone, covering up their mirrors, wearing lighter shades of makeup, bleaching their skin, wearing colored contacts. Race socialization is a vital component in the development of children in racialized families. The literature and research shows that race socialization can serve as a protective factor in racialized families because it provides family members with racial, ethnic identity resiliency and various coping mechanisms. And what else we see, the stress of dealing with colorism can also lead to things like social withdrawal and isolation. So people just don't want to be around other people. Facing frequent color discrimination leads others to just step away from the world. And the withdrawal can exacerbate feelings of loneliness, and the impact can, obviously, we know, have a further toll on one's mental health. Colorism really marginalized people, in their own communities as well. That social exclusion limits their access to resources and opportunities. This marginalizes an individual and creates a sense of inferiority. It can impact one's relationships, social interactions, and overall sense of belonging to various social systems in their life, maybe their friend circle, maybe their family, or the larger community that they belong to. So children and youth, we know, learn by what they see, right? So without the protective factors that I've just chatted about, providing that cushion and that resiliency building, it's easy for people to be swayed by factors such as media and popular culture. So bringing it back to your field, the dermal sciences field, as professionals in the dermal sciences field, understanding and addressing colorism is crucial for several reasons. So for all of you providing holistic patient care, right? So you want to be able to provide comprehensive, holistic care for all of your patients. And it's important to consider the sociocultural and psychological dimensions of skin health. So recognizing the impacts of colorism allows one to offer more empathetic and effective treatment plans that addresses both the physical symptoms and underlying stressors that Dr. Culbreth was talking about. Advocacy and education, right? We all have a role in advocating against harmful practices associated with colorism, such as the use of unsafe skin lightening products. So educating patients about the risks of these products and promoting safe alternatives is a responsibility that must be embraced and practiced. Professional practice, so by fostering a more inclusive and culturally competent practice, you can challenge biases within your own institutions and ensure equitable treatment of all of your patients. This will involve incorporating cultural sensitivity and awareness into training, practice, and within your patient interactions. And the broader social impact, right? So engaging in those conversations, those dialogues about colorism within your professional sphere, this is going to help contribute to broader societal change. So by addressing these issues publicly and within your practice, you can help shift societal attitudes and support the movement towards greater inclusivity and equity in the field. And I want to leave you with a few strategies, that will help you address instances of colorism that requires more of a collective effort and systemic change. So some actions that you can take, education and awareness, we've talked about this. So implementing regular training programs focused on cultural awareness that educate practitioners about the historical and social implications of colorism is really, really important. This will enhance their understanding of diverse client backgrounds and improve their ability to provide empathetic care. Inclusive marketing and representation. So ensuring that marketing materials, educational resources, and clinical environments reflect a diverse range of skin tones and skin types. This representation is so, so important. It can really help clients feel seen and valued, fostering a more welcome environment. Where do we feel more connected, right? Where we see people that look like us, that talk like us. That's a really important thing. And then the third thing is personalized consultations. So conducting thorough consultations that prioritize the unique experience and concerns of clients related to their skin tone. Practitioners should ask open-ended questions to understand how colorism has impacted their client's body image and personal identity, allowing for more tailored treatment plans. The promotion of positive skin narratives. This is so, so essential. Actively promoting narratives that celebrate diverse beauty standards within your practice. So this can include client testimonials, educational campaigns, and community outreach initiatives that highlight positive representation of all skin tones. Collaboration with maybe community organizations that are around you. So partnering with local organizations, NGOs, maybe that are focused on equity and mental health work. Maybe they can host workshops and discussions on colorism. This collaboration can really create a supportive community network. It's going to continue on with that dialogue and provide clients with resources that address the psychological impacts of colorism. Policy and legislation, so supporting policies and legislation that prohibits discrimination based on skin color in health is so essential, and using that intersectional approach that I was talking about earlier. So addressing the multiple layers of oppression and the compounding effects is important. So for example, collaborating with the organization and movements that address intersecting forms of discrimination, such as racial justice, gender equity. These types of initiatives would really move things forward on creating change on this issue. And then challenging industry practices. So holding industries accountable for promoting colorist narratives and practices. So such as companies that are selling these skin lightening products, these bleaching products, and discriminatory beauty standards are greatly needed. The multinational companies profit off instilling insecurities in others, and we need legislative change that is going to push for ethical and responsible marketing that promotes diversity and inclusivity, and not just pushing these kinds of dangerous skin lightening products. So for example, holding companies accountable for promoting these types of products, maybe boycotting or stopping people having a movement where everyone stops buying these products, because if no one's buying them, then they're not going to sell, they're not going to be on the shelves anymore. The power is in the consumer's hands. So support ethical brands and initiatives that prioritize diversity, sustainability, and social responsibility in the marketing and production practices. So by implementing these strategies in your practice in dermal sciences, you can work towards creating positive change and combating colorism in our communities and beyond. It does require a collective effort. It's power in numbers to challenge biases and foster a culture of celebration of all skin.
Thank you, Dr. Sarda, for your compelling insights. Your focus on mental health is essential in our discussions about colorism. Thank you for joining us. On behalf of our entire team, we extend our heartfelt gratitude to our distinguished speakers from the United States. Your insights and expertise have enriched our discussions today, providing invaluable perspective that have left a lasting impact. Your contributions today have truly elevated our conference, and we look forward to future opportunities for collaboration. Thank you once again for joining us and for sharing your wisdom and passion with us. Our next speaker is Dr. P. Ravishankar, joining us from Malaysia, a distinguished faculty member at the International Medical University in Kuala Lumpur, Malaysia. With an impressive 767 publications and contributions to 14 book chapters, Dr. Shankar has been recognized among the top 2% of scientific globally for 3 consecutive years. He has reviewed over 840 research papers and is a member of several prestigious organizations, including the ORCID Research Advisory Council and the World Association of Medical Editors. He is contributing author to Routledge's International Handbook of Colorism. Today, Dr. Shankar will be discussing perception, practice, and self-reported adverse effects of skin lightening products among female health students at Gandaki Medical College, Pokhara, Nepal. Dr. P. Ravishankar has been a consistent speaker in the previous three editions of the international conference. We are pleased to have him continue his valuable participation this year as well, and we appreciate his ongoing commitment to our conference. Dr. Shankar, we are honored to have you with us.
On perception, practice, and self-reported adverse effects of skin lightening products among female health science students at Gandhagi Medical College, Pokhara, Nepal. I'm Dr. P. Ravishankar, and I would like to thank the organizers of ICDS 2024 for inviting me to present at this conference. And I've also presented at previous conferences of previous versions of ICDS. So this study was done along with Dr. Sabita Paudel, who is a faculty at Gandhagi Medical College, Ms. Razina Bania, who was a pharmacy student at that time, and currently she works at Birendra Hospital in Kathmandu, and I'm Dr. P. Ravishankar. So Nepal, as you're well aware, is a South Asian country located in the Himalayas. A large part of Nepal is in the Himalayas. Nepal is known as the land of Lord Buddha and also known for Mount Everest, the highest point on earth. Nepal is a land with a lot of diversity, cultural and ethnic diversity. And Nepal, just like many other South Asian countries, there's a preference for fair skin. And skin color is one of the factors that determines a person's position in the social hierarchy. So there is a strict social hierarchy, even though things are now changing. So your position in the hierarchy, among other things, is determined by your skin color. So this may have been due to British colonial rule in neighboring countries, though Nepal was never colonized by the British. Neighboring countries were, and Nepal fought wars with the British, and eventually there was a British resident posted in Kathmandu. And English is today the language of higher education, as we will see when we come to the study. So fairness is associated with a variety of positive attributes, including beauty, purity, higher position. So fairness is something which becomes a coveted object. Fairness indicates that you're rich, you're powerful, you need not work in the sun to earn your living. While people are not fair, many of the negative attributes get associated with these individuals. Skin lightening products, due to this preoccupation with a fair skin, a variety of skin lightening products are used by individuals to attain fairness. So fairness has been marketed as something which you can get from a product, maybe from a tube of a lightening product, maybe from a cream. So this preference for a fair skin is something which has been marketed, and market lightness comes from you use a preparation and you become fair. So that's how it has been marketed. Fairness has been associated with beauty. So to be beautiful, you have to be fair. And this is also seen in multiple media. If you look at different films, the film industry, especially in India, most of the actresses, especially the female actresses, usually are fair. And fairness has been associated with beauty very much. So our objective was to assess the perception, practice, and self-reported adverse effects of these skin lightening products among female health science students at Gandhagi Medical College in Pokhara, Nepal. So Gandhagi Medical College offers courses in a variety of subjects related to the health sciences, including dentistry, nursing, pharmacy, and other subjects, which we'll now see. So coming to the methodology, this study was done from November 2021 to April 2022. So this was the time of the COVID-19 pandemic. Waves of the pandemic struck different countries, as you may be well aware. This was a descriptive cross-sectional study among 309 female students of the institution. We obtained consent, written consent when it was done face-to-face, online consent when the study was being done online. Female students above 18 years of age who provided the consent to participate were included in the study, and they belong to different undergraduate programs, as we'll see shortly. So we modified a valid questionnaire, validated questionnaire from a previous study. We did pre-testing among a big group of students, about 46 female students. This provided a Cronbach's alpha, which is a measure of internal consistency of 0.7. And this is a good value. We also obtained feedback from 5 female students. We asked them how easy it was to comprehend, to understand the questions, whether they would like any changes to how the questions were sequenced, and whether they found it easy to complete the questionnaire. We calculated frequency, mean, and standard deviation as part of the demographics. And we also compared perception and between students who use skin lightening. SL stands for skin lightening products. Those who use skin lightening products and those who do not use these products. Most students were between below 25 years of age, as they're all undergraduate students from different programs. This is to be expected. Most were from MBBS or medicine. We also had students from BDS, dentistry, nursing, Bachelor of Pharmacy, Bachelor of Public Health. Most were unmarried students. Again, this is to be expected. Most distributed among the different years of study. Most programs are only 4 years. So maybe most of the fifth year students are from medicine. And most were from a rural background or a semi-urban background. And a large percentage of students were from the dominant hierarchical groups in Nepal. So that's the Brahmin and the Kshatri. So these are the two dominant groups in the hierarchy. We also had Nevas, which is an ethnic group originally from the Kathmandu Valley. And then you also had Jananjatis and Dalits and few people from the plains of Nepal. So Nepal, Pokhara is situated in the hill region of Nepal. It's a valley. Skin color, according to Fitzpatrick's skin type. So this depends on the amount of melanin. So most students, were between, I think, types 3 and 4. So the amount of melanin pigment, so that is determined, one is it's determined constitutionally. The farther away you are from the equator, the lesser the amount of melanin in your skin. And when you are exposed to ultraviolet radiation, that stimulates the production of melanin, what we call as tanning. So melanin is actually a protective pigment, protecting people from ultraviolet rays of the sun, especially in regions near the equator. So these are different statements. We looked at respondents' agreements with different statements. And as you will notice, for most of the statements, there were no differences between users and non-users. If you look at the p-value, there is no significant difference. Like we looked at, there's a common preconception whether skin is beautiful, gives women more confidence, makes women look younger. And most of the statements are positive. So common, what you call preconceptions, common misperceptions. So those were what we tried to explain. Men consider women with lighter skin more beautiful. Advertisements influence a woman's preference for a lighter skin, which many agreed with, of course. And skin lightening products may cause undesirable side effects. Again, quite a lot of students were aware since they were from the health sciences. Active ingredients should be carefully noted, which again, most students agreed. Cost is important, yes, but not everyone fully agreed. And like many others, they often thought that if it contains a herbal extract, then it is safe. So a large percentage, about 78%, had used skin or were using skin lightening products. And they started quite early, around 17 and a half years. So that may be around the age. Some studies show maybe people start using them even earlier, maybe 14 or 15 years of age, due to various factors. And most often, they bought it in a supermarket or a convenience store, since you don't need a prescription to buy a skin lightening product. And most often, it was either self knowledge or advice from friends. That's how they chose a skin lightening product. And most used it either for a pigment disorder or because they prefer a lighter skin. And many applied it once a day. So and they used about 2 skin lightening products at one time. Many of them, but not all, a good percentage. And they usually applied it on the face and neck because these are the parts which I usually see and which are, again regarded as symbols of beauty. So many of them were encouraged by advertisements, if you look at this, or by friends. So those were the two most common sources who encouraged them to buy these products. They usually considered ingredients, recommendation, and price. Price was also an important factor. And the advertisement was always there in the background. And they spent quite a good amount, about 900 to 1,000. A lot of them spend about, some spend even more than Nepali rupees, 1,200. So one Nepali rupees, one US dollar is around 130 Nepali rupees. So a lot of money has been spent on buying the skin lightening products. These are the ingredients which were mentioned by the participants, which different ingredients which these preparations contained. And to conclude, so if you look at what our study has showed, among female students in a health science institution around the city of Pokhara in Nepal, most of them use skin lightening products, a good percentage. And a variety of factors influence their preference for a fair skin. So this included maybe recommendation from friends, peer pressure, advertisement, suppose benefits of a fairer skin, how fair skin will help in the social and professional advancement. So in future, we would be interested in doing a qualitative study, focus groups, or semi-structured interviews with respondents to actually explore this phenomenon in more detail. Thank you very much.
Thank you, Dr. Shankar, for your detailed and insightful presentation. Your research on the perceptions and effects of skin lightening products has provided us with critical insights. If anyone has a question, you may ask.
Sir, I wanted to ask one advice you would like to give to our audience regarding skin lightening products, as majority of our audience is skincare experts.
I think, because thank you for the question. So this was actually among students, health science students. So there's a widespread preference for a lighter skin. As I think you know that multiple our parts, South Asia, many Asian countries. So I think even if people are professionals, I believe due to various pressure, we know it may not be proper. They might have issues, but maybe due to family pressure, maybe societal pressure, because many of these students did know about these skin preparations. They knew what could be the problem. They knew what it was all about, at least to a certain degree, but still many of them used it because they wanted to, maybe due to various reasons, peer pressure, societal pressure, the advertisements in the media, and all that, association with success. So I believe it's not very easy, even though we may be healthcare professionals and we know something about these, it still may not be that easy not to use this. Again, I believe we do not teach that much. I don't know how much you teach in Pakistan. In many other parts of the world, we just mention this in passing. This is not a topic which is which is not, what I call taught in detail in medical school or in other institutions. So that's, I believe people will still, due to various reasons, you might still end up using those products, especially those who are of darker skin color. So that's what I would like to say. Thank you.
Thank you, Dr. P. Ravishankar. Next, I'm honored to introduce Ms. Sana Arshad, Doctor of Dermal Sciences and cosmetologist at Signature Aesthetics. Her pioneering work in cosmetic sciences, aesthetics, and social sciences has earned her recognition. Ms. Sana Arshad is the alumnus of the University of Faisalabad. She was one of the key persons who conceptualized ICDS and successfully conducted first and second edition as a conference coordinator and was the focal person for international linkages in third ICDS. She is the youngest contributing author to Routledge's International Handbook of Colorism. Today, she will be sharing her insights on Shades of Prejudice, Unpacking Colorism in Pakistan. Ms. Sana Arshad, we are excited to hear your perspectives. Please welcome Ms. Sana Arshad.
Thank you so much for the kind introduction, Afaf. Okay, so the title of my talk today is Shades of Prejudice, Unpacking Colorism in Pakistan. When I was choosing the title, I wanted it to embody the colorism that is actually happening in Pakistan. Now, in Pakistan, we experience intraracial colorism, which is that staying in the same race, we are still prejudicing and discriminating people on different shades of their skin. So that's why we are going to unpack the colorism of Pakistan, which is the prejudice of shades. And next. Now imagine being told that the most important thing about you is your skin color. How would that affect your self-worth? And that is the story of nearly every individual who is dark skinned in Pakistan. We are always told that given your skin tone, given the skin tone of your siblings, your class fellows, your achievements, your success are nothing because your physical attributes are not according to what we think is beautiful. Now that is going to hurt and traumatize your self-worth. And that is what we're going to talk about today. Now, given that Pakistan is a country, a very beautiful country of multiple ethnicities, multiple cultures, multiple languages, we have a very different variety of people among us. But living in these different ethnicities, we should be more welcoming towards different ideas, different perceptions, and accepting people. But that is not the case. And now let's explore why that is. Now, Pakistan is a home for 246 million people, nearly. And given that 96% of that population is Muslim population. So not only Islam is the state religion, it also impacts the rules and legislation very much. So given that, we should think that Islam should also have a very important impact on our perceptions. That is true, but to some extent. Now let's see how the colorism acts into that. Now, in the last sermon of Hazrat Muhammad sallallahu alaihi wasallam, our last prophet, he said, "All mankind is from Allah and Adam and Eve. An Arab has no superiority over a non-Arab. A non-Arab has no superiority over an Arab. A white has no superiority over a black. A black has no superiority over a white unless of piety and good action. So, in the last sermon, it was very clearly stated that no black has superiority over white or white superiority over black unless you are doing good action. So we should think that when in our state religion something is stated so clearly that this should not be a problem, but it still is. So let's dig into the history of our geographical state to see if we can find the root problem there. Now, our history comprises of two main eras, the Mughal era and the British colonization. Now, the Mughal period started in 1526 and it reigned over nearly 3 centuries. The Mughal era was of grandeur and luxury, of art and of music. During this Mughal era, we had two main influences, aesthetic ideals and casteism, which impacted colorism greatly. In our aesthetic ideals during Mughal era, they were very influenced by the Persian people, their aesthetics, their skin, their way of living, their art. So when the court was being painted or art was being presented, the one which was presented in a very Persian way or in a fair-skinned way, it was more impressive and more needed by the Mughals. So basically, they wanted more Persian into their culture. Next is casteism. The Mughals era is known for its casteism. Now, because the lower caste was used to working outdoors a lot, they had very tan skin. So from there, tan skin started to have a very low impact, and white was given superiority and a symbol for the higher caste. So from there, it started. The next is the British colonization. Now that started in 1857 and stayed for over an century. Now the British colonization, when it started, given that the British had white skin, it in itself gave a white superiority that we always saw our superiors as white, which gave the impact that white is superior. And they also started a martial race. In martial race, they wanted to have loyal soldiers. So from the subcontinent, what they would do is they would have people with Eurocentric European physical attributes and add them to this martial race and give them more benefits. So that also added to this whole scenario, and that is where the root problem of colorism in our mind started. Now that we have talked about our history and how it generated, let's talk about why is it happening. So intersubjective perceptions are basically the perceptions that we see in a culture. Now these are the perception that we all share together, and these are greatly impacted by three things: individual perception, inter-individual perception, and supra-individual perceptions. In individual perception, we see the ideas or perception that I as an individual is feeling. In inter-individual, we see that as a society, I feel like I share with you guys. And in supra, it is the perceptions or ideas that I feel like on a cultural basis, these are being practiced. So what this gives us is that even though what we perceive is different, if we think that something is being perceived by our culture is going to make us more accepted, we will still accept that rather than our own perception, and it will influence that, even though it might contradict our own ideals. The next is the psychosocial impact of colorism. Now, colorism starts from the mother's womb. And I don't say that very lightly, I mean that literally. Now, when a woman is pregnant, the most common thing that we see in our society are the myths. Please eat more apples, your baby will be white. Don't drink too much tea, your baby will be dark. So literally the impact of colorism is starting when the baby is in the mother's womb. And from that, it carries on to the different stages of the girls or the boy's life. Then we go to the childhood phase. I still remember when I was in my second year, that was the first interaction that really hit me about colorism, that a mother presented in the OPD with a 6-year-old daughter and asked the doctors there to prescribe whitening creams for her. As a second year, that was a very horrifying experience for me, and it stayed with me still, because I was thinking that how is it possible that a mother is taking her daughter to the doctor because she thinks her darker skin is a disease and needs to be treated. And then it goes on to school and moreover. Now, the impact of media is also very great in this. Through advertisements, we are constantly promoting lighter skin, and the heroines in our the main lead roles are definitely fairer skin tones. In literature, we also see that our poets are depicting the main characters as lighter skin, and the physical attributes spoken in the poets' words are for the lighter skin ladies. Now, the impact on dermatology and aesthetics practice. It has a lot of impact on the dermatology and aesthetic practice. First of all, by using whitening creams, what you're doing is you're making patients. You are actually harming your skin more, which will give you more diseases like rosacea, acne, and so much more, hirsutism, which in turn will give you more patients. The harmful effects, the anxiety, the depression is an added pressure, and the increased pressure on practitioner to prescribe whitening creams or glutathione injections on the patients is also there. Now, I had a patient in my aesthetic center where a mother came and she was very sad. Her daughter was a chemical engineer, and she was, her literal words were कि मैंने अपनी बेटी के ऊपर कभी कोई पैसा नहीं लगाया, बचपन से लेकर यूनिवर्सिटी तक वो हमेशा स्कॉलरशिप पे पढ़ी है, लेकिन आज मुझे उसे गोरा करने के लिए उसको इंजेक्शंस लगवाने पड़े हैं और मुझे लाखों देने पड़ रहे हैं. So that is the impact colorism is having over our society, that our ladies and our male have to go through all this trauma and challenges. Now, the conclusion to this is that we need to take the path forward. We need to think about how to tackle this. We need to have more seminars, more conversation, more discussions about it. We need to call for a change, and that change doesn't have to be over international or a very big change. It has to start with you. Even if you go today and have a discussion with your friends and your family that from now on, I will not judge anyone on the basis of their color or physical attributes, then I think we will make a great change with that. Thank you. I would like to give a very special thanks to my co-author, Dr. Tanzila Khalid, without whom this wouldn't be possible.
Thank you, Ms. Sana Arshad, for your powerful and enlightening presentation. Your exploration of colorism in Pakistan has shed light on important cultural dynamics. We greatly appreciate your time and talk today. Now, at this time, I invite Dr. Sana Arshad to take the floor for the book launch ceremony of the International Handbook of Colorism.
Welcome to the 2024 International Conference on Dermal Sciences. My name is Dr. Ronald E. Hall. Currently, I am a professor at Michigan State University in the US. I've been studying colorism for about 30 years. Early in my career, I focused on African Americans. However, I realized that colorism pertains to all people of color worldwide. As a result, I began traveling internationally as I have visited every major racial population on the planet. By conducting focus groups and collecting surveys on colorism, I have witnessed the manifestations of colorism impacting all of humanity. Therefore, it was always my intention to publish a book on colorism conveyed in a worldwide context. This led me to my latest book project, co-edited with Dr. Neha Mishra. The title of our work is the Routledge International Handbook of Colorism. This book contains 22 chapters with selections that include Pakistan. The Routledge International Handbook of Colorism is being launched at the International Conference of Dermal Sciences at the University of Faizabad, which is the first such conference in Pakistan, and I believe the world. Giving her all due credit for conducting the conference, I would like to thank Dr. Tanzila Khalid, who I believe is one of the world's leading authorities. Subsequently, I feel privileged and honored to take part in this event. Thank you and enjoy the activities.
Bismillahirrahmanirrahim. Honorable guests, respected colleagues, and dear conference delegates. I'm delighted to stand before you today at the Routledge International Handbook of Colorism launch. It is an honor to share this platform with our esteemed editors, Professor Ronald E. Hall and Dr. Neha Mishra, whose dedication to this project has been inspiring. It was really motivating to be among authors from 6 continents who contributed to this remarkable project. I want to share my pride at this moment that this chapter, Colorism in Pakistan, was co-authored by me and my talented student, Sana Arshad, a proud alumnus of the University of Islamabad. Our journey in writing this chapter began during the first International Conference on Dermal Sciences, where the conference theme was colorism. We realized that we share a passion for understanding and addressing this pervasive issue of colorism in our country. Colorism has deep roots and profound implications for individuals and communities. It intersects in Pakistan with cultural, social, and economic dimensions, influencing the perceptions of beauty, opportunity, and identity. Through our work, we aim to shed light on these complex dynamics and start a meaningful discourse. Today, as we gather to celebrate this collective effort, I hope our work will contribute to a greater understanding of colorism, inspire further research, and foster a dialogue that promotes equity and inclusivity. I would like to express my sincere appreciation to the University of Islamabad, the institution that I've been a part of for the last 18 years, for fostering a supportive and intellectually stimulating environment that has enabled me to pursue my research and contribute to the field of colorism studies. Thank you all for being here and for showing your support for the cause. Let's continue to challenge and reshape the narratives that surround colorism in Pakistan. Thank you very much. So for the official launch, we will just have a photograph and we want to.
I would like to take this opportunity to request Conference Chair Professor Dr. Tanzila Khalid to present Conference souvenir as a speaker to us.
Acha. We replace the shield with a syrup.
Bismillahirrahmanirrahim. In the name of Allah, the most gracious and most merciful, honorable guests and respected conference delegates, Assalamu alaikum. I am Prihan Fatima, President, Society for Skincare. On behalf of the organizing committee, it is my privilege to welcome you all to the inaugural session of the 4th International Conference on Dermal Sciences. To begin this auspicious occasion, I invite Haika Rashid for the recitation of Holy Quran, and along with her, Ms. Aisha Batul, to honor us with a soulful naat in praise of our beloved Prophet Muhammad, peace be upon him.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم كلا الإنسان ليطغى أن رآه استغنى إن إلى ربك الرجعى صدق الله العظيم. I seek refuge with Allah, the accused shaitan. In the name of Allah, the especially merciful, the entirely merciful. Read in the name of your Lord who created man from a clot of congealed blood. Read and your Lord to most generous, who taught knowledge by the pen, taught man the which he did not know. Nay, indeed, man transgress inviliously, because he sees self-sufficient. Indeed, to your Lord in the return. Thank you.
मेरा पयंबर अजीम तर है, मेरा पयंबर अजीम तर है, मेरा पयंबर अजीम तर है, कमाल ज़ात उसकी, जमाल हस्ती हयात उसकी, बशर नहीं अज़मते बशर है, मेरा पयंबर अजीम तर है। शौर ला किताब ला, शकता निसाब लाया, दिया कि कामिल नजाम उसने, और आप ही इनकलाब लाया, वो इल्म की और अमल की हद भी अजल भी उसका है, और अबद भी वो हर जमाने का राहबर है, मेरा पयंबर अजीम तर है, कमाल खल्लाक ज़ात उसकी, जमाल हस्ती हयात उसकी, बशर नहीं अज़मते बशर है, मेरा पयंबर अजीम तर है।
Jazakallah. It is my honor to introduce our chief guest, Professor Dr. Sayyid Asghar Naqi, Principal, Allama Iqbal Medical College. He graduated from King Edward Medical College in 1993. He did his FCPS from the College of Physician and Surgeon Pakistan in 1998 and FRCS from the Royal College of Surgeons, Edinburgh in 2000. Before acquiring the current position as Principal, Allama Iqbal Medical College, he served in various vital positions at King Edward Medical University, Lahore, such as Chairman of the Department of Surgery, Dean of Allied Health Sciences, Registrar of University, Director of QEC, Director of PG Committee, Director Program of Surgical Technology, and rendered multiple other services. Moreover, he served as Program Director and faculty member of MCPS, Lahore, and Director of Medical Education at Postgraduate Medical Institute, Lahore. He has published 93 papers in national and international journals and has won over 20 national and international awards. He has delivered more than 70 keynote lectures and presentations and was awarded the Best University Teacher Award by HEC in 2021. I request Dr. Syed Asghar Naqi to kindly come on stage and chair the inaugural session. Thank you, sir, for gracing us with your presence. Next, I invite Professor Dr. Amanullah Malik, Pro-Rector of the University of Faisalabad, to please come to the stage. Thank you, sir. We value your presence among us today. Dean Faculty of Sciences, the University of Faisalabad, Professor Dr. Amir Ali Chaudhary, please proceed to the stage and take your seat. Thank you, sir, for your presence. Please join me in inviting Registrar, the University of Faisalabad, Madam Zahida Maqbool. Thank you, ma'am, for joining us. Principal, University Medical and Dental College, Professor Dr. Akram Malik. Sir, kindly take your seat on the stage. Thank you, sir. We're honored by your presence. Conference Chair, Professor Dr. Tanzila Khalid, we invite you to join the stage, please. Thank you, ma'am. I request Conference Chair, Professor Dr. Tanzila Khalid, Dean Clinical Training, Faculty of Medicine and Allied Health Sciences, and UMDC, Head Department of Dermatology, to introduce the conference.
The perks of being a conference chair is that you get to speak twice. Bismillah ar-Rahman ar-Rahim. Honorable Chief Guest, Professor Syed Asghar Naqi, Principal Allama Iqbal Medical College, Professor Amanullah Malik, Pro-Rector, the University of Faisalabad, Professor Amir Ali Chaudhary, Dean Faculty of Sciences, Madam Zahida Maqbool, Registrar, the University of Faisalabad, Professor Muhammad Akram Malik, Principal, University Medical and Dental College, worthy guests, and respected conference delegates of ICDS 2024. Assalamu alaikum. On behalf of the organizing committee, I welcome you all to the 4th International Conference on Dermal Sciences. ICDS is an interprofessional platform that was conceptualized by the Department of Dermatology in 2021 as a solution-oriented approach to skin-related issues. ICDS 2024 is the 4th conference of this series with the theme Skin Connects. The success of the conferences in 2021, 22, and 23 has proved ICDS to be a dynamic platform for experts, researchers, and professionals from around the world interested in the field of dermal sciences. We believe that solutions to complex issues require integrated efforts by positive minds. The conference welcomes a diverse range of participants, including cosmetic scientists, dermatologists, allied health professionals, cosmetic industrialists, legal experts, social scientists, educationists, and anyone who is interested in skin. This year, 9 pre-conference workshops were conducted on diverse topics, including management of neuropathic feet, suture techniques, wound management, aesthetic procedures, hair care product development, the use of sock slit extraction techniques for natural extracts in cosmetic products, and the use of AI in research. These workshops were attended by 400 participants with a very good feedback. Okay. With around, with around 500 registered participants, 20 guest speakers, and 30 presenters from 7 countries, including USA, Canada, China, Malaysia, Egypt, India, and Pakistan, we look forward to a rich and diverse discourse on how skin connects us. Special features of the 4th ICDS are a plenary session on colorism that is a consistent theme since our first conference in 2021, along with the book launch that you just witnessed. A unique session on skin and linguistics, with researchers discussing how literature impacts our beauty standards. A session on the role of allied health education in achieving sustainable development goals, and an interdisciplinary session on the importance of skin science in diagnosing and managing systemic diseases in pediatrics, gynae, and breast surgery. A separate session on pharmaceuticals where researchers will present their work on the preparation and use of nanocarriers, hydrogels, and micellar solutions in dermal, transdermal drug delivery will also be conducted, inshallah. I am really grateful to our worthy chief guest for sparing time out of his busy schedule and traveling to Faisalabad to attend this session. I thank all the respected guests and keynote speakers and conference delegates and hope that ICDS 2024 will, inshallah, live up to your expectations. Thank you.
Thank you, Professor Tanzila Khalid, for your insightful words and for setting the tone for this conference. Your leadership and guidance continue to inspire us as we strive for excellence in the field of dermal sciences. I now invite Professor Dr. Amanullah Malik, Pro-Rector at the University of Faisalabad. With his exceptional leadership skills and unwavering commitment to academic excellence, Dr. Amanullah has been a pivotal force in tough community. Please join me in welcoming Dr. Amanullah to deliver the welcome address.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اللهم صل على محمد وعلى آل محمد وبارك وسلم. Honorable Chief Guest Professor Dr. Syed Asghar Naqi, Principal, Allama Iqbal Medical College, Lahore. Professor Dr. Amir Ali Chaudhry Sahib, Dean Sciences. Madam Zaida Makbul Sahib, Registrar of the University. Professor Dr. Akram Malik, Professor Dr. Tanzila Khalid, Convener of the Dermal Conference, Deans, Directors, Faculty Member, Dignitaries, International and National Speaker, Researchers, Participants, and very dear students, Assalamu alaikum and a very good morning. On behalf of the University of Faisalabad, it's my distinct pleasure to welcome you all to the 4th International Conference on Dermal Sciences, an event that continues to set benchmarks for innovation and collaboration in this field. As a Pro-Rector and Director ORIC, I am proud to witness how the Dermal Sciences has taken this initiative in organizing this prestigious conference, which has become a hallmark of our university's commitment to academic excellence. It is well known that universities are places for innovative ideas and providing solutions to the new challenges. Intelligent and smart people choose the emerging field to be successful, while the visionary people make the new fields to emerge and take initiative for the benefits of the society at large. Starting dermal science and ICDS at TUF is one of the examples of great vision, for which I would like to congratulate Professor Dr. Tanzila Khalid and her team, which has been very well supported by our worthy Chairman, Board of Director, Mr. Mohammad Haider Amin, our Rector, Professor Gilani, and our Registrar, Madam Zaida Makbul Sahib. Since the launch of IDCS, it has served as a platform where great ideas meet practical solutions. And this year's theme, Skin Connects, is timely and crucial for delving into profound ways in which the skin connects with various disciplines and aspects of our lives. I eagerly anticipate the engaging discussions and innovative insights that will arise from this conference. I'm confident that the collaborative effort of all the participants will not only enrich the understanding of dermal science, but also foster the advancement that will contribute significantly to the continued success of dermal science and the University of Faisalabad. Lastly, I would also like to congratulate Professor Dr. Tanzila and her student and all those contributing authors for launching this innovative book, because this is probably the first book internationally which has been published. It's an inspiration for our other faculty members too, that take such initiative which are unique and which will certainly contribute. This book certainly will become as an academic reference, and Dr. Tanzila Khalid has, with her contribution, inshallah, this is kind of sadaqah jariyah. And I hope it will go a long way for the advancement of the understanding and promoting the cause. Thank you all. Allah.
Thank you, Dr. Amanullah, for your warm welcome and thoughtful insights. We are grateful for your continued leadership. Now, I request our worthy chief guest, Professor Dr. Syed Asghar Naqi, Principal, Allama Iqbal Medical College, to kindly deliver his address.
Thank you very much. Professor Amanullah Malik Saab, Pro-Rector, Professor Zaida Maqbool, the Registrar, Amr Ali Choi Saab, Dean Sciences, Professor Akram Malik Saab, Principal, and Professor Tanzila Khalid, Chair of this organizing committee of this conference. Ladies and gentlemen, esteemed guests, distinguished faculty and participants, Assalamu alaikum. It is both an honor and privilege to address this esteemed gathering as the chief guest at the University of Faisalabad's 4th International Conference on Dermal Sciences. And I would like to extend my profound appreciation for the productive conference which is taking place today, showcasing the collective expertise in the vital field of dermal sciences. It is truly inspiring to witness such a well-organized event that brings together experts from various fields to explore the advancements in dermal sciences. Now, in contemporary society, the significance of appearance cannot be overstated. हम सब बचपन से सुनते आए हैं, beauty is skin deep. Now, what does that really mean? When you meet somebody, when you see somebody, the first impression that you get from that person is from the complexion and the skin color of that person. And I must be thankful to Professor Tanzila that I have never been exposed to the word colorism and what it actually means. And while I was coming to this conference, I got the opportunity to read something about this colorism, and then I could visualize and see various experiences of my own life where it has impacted in various manners. Our complexion and the broader field of cosmesis have become the integral components of personal identity, self-esteem, and social dynamics. As dermatologists, researchers, and professionals in this vital field, we must acknowledge and explore the multifaceted impact of skin health on overall well-being of any individual. As you all know, that skin is the largest organ of the body. And I, being a general surgeon, while we were being trained and we were receiving all those burns patients, the most important thing that would decide the fate of that patient of burns would be the amount of skin area that was burnt and the depth of the skin which was burnt. It would result in the life and the subsequent life events of that person. So this is how the skin maintains our health and how it is important to maintain the health of our skin ourselves. As medical professionals, we understand that skin health is not only a reflection of external care, but also an indicator of internal well being. That emphasizes the theme of this conference, that skin connects. And it is a very engaging concept to know that skin connects. I'm delighted to witness this initiative by the University of Faisalabad. And sir, I'm most suitably impressed by the conduct of this conference, the way it has been organized in such a wonderful manner, and the way that you people are doing such a wonderful work here. So, to bring this crucial subject to the forefront of global disclosure, and I was just hearing the comments from the professor from University of Michigan, in which he said that this is perhaps the first time that any conference in the world is taking place which is talking about colorism. I, for one, can vouch for that, that I have never been exposed to this term before I knew about this conference. So it is inspiring to see that how such platforms can bring knowledge and also bridge the knowledge gaps, foster collaboration, and stimulate research across various disciplines. Now we all know that there are psychological impacts of complexion, as was being narrated by one of the co-authors of Professor Tanzila's book. The person's complexions plays a pivotal role in shaping the self-perception and mental health. Skin conditions, besides the skin tone, such as acne, hyperpigmentation, eczema, scarring, can have profound psychological effects. So, once again, I remember being a medical student, we were told that the causes of death due to burns all started from S, and the last one was suicide because of scarring. And that is a real term. If you have worked with the victims of acid vitriolage, you must have known, you must have seen patients who suffer those kind of scars, which completely tarnishes their physical appearance and also their mental well-being. They lead to contacting suicides, and that is a real risk that people have with scarring. Now, not only that, but also research indicates that individuals which are affected by these conditions, they often experience low self-esteem, anxiety and depression, and social withdrawal. Conversely, a clear, healthy complexion can serve as a powerful confidence booster, enhancing one's quality of life, social interaction, and overall emotional resilience. We know that media plays a very important role in shaping our perceptions of beauty. आप सब ने वो गाना सुना होगा, गोरे रंग दा ज़माना. We all have heard that song, and that song was very popular. But there was a large reaction to this song. And subsequently, that group also had to sing Savali Saloni. So, sir, colorism was impacting us, though we did not know at that time why was this happening and why somebody who was singing about Gore Rang Da Zamana would have to forcefully sing Savali Saloni. So, the perpetuating unrealistic standards that equate flawless skin with attractiveness, this cultural narrative can lead to an increased desire for cosmetic procedures and products. The implications are significant. The global skincare industry is projected to reach an astounding $183 billion plus by 2025. Furthermore, it reveals that 68% of women and 52% of men, they consider the skin appearance as a critical factor in evaluating attractiveness, underscoring the societal pressures around the cosmetic ideals. Now, despite these challenges, the field of dermal science has witnessed remarkable advancements. Innovation, they have led to a range of effective treatments that address various skin concerns. And among these are the non-invasive treatments, procedures such as the chemicals, microdermabrasions, minimal invasive procedures like botulinum toxin injections, laser technology, and then nanotechnology-based skin care products. The integration has enhanced the efficacy and absorption of active ingredients in topical formulations. They offer tailored solutions to our patients. These innovations empower individuals to achieve their desired aesthetic outcomes, contributing positively to their mental health and self-image. But as experts in dermatology and related fields, we bear a responsibility to navigate the complex relationship between complexion, cosmesis, and overall well being. Our collective goals should include promoting realistic beauty standards. We must advocate for a more inclusive definition of beauty that celebrates diversity and encourages self acceptance. Advancing research and development. Continuous investment in research is essential to uncover new treatments and improve existing ones, ensuring they are safe, they are effective, and they are accessible to all. Ensuring accessibility and affordability of treatments. We must strive to provide equitable access to dermatological care, enabling individuals from all backgrounds and all walks of life to benefit from advances in skin health. And educating the public on skin health. Public education initiatives are crucial to inform individuals about proper skin care, the psychological impact of skin conditions, and the options available for treatment. In conclusion, let us recognize that intricate interplay between complexion, cosmesis, and overall well-being is imperative that we as community of professionals collaborate to foster an environment that empowers individuals to achieve and maintain a healthy, radiant skin of whatever skin tone it is. Together, we can revolutionize the field of dermal science, not only enhancing the aesthetic outcomes, but also promoting the holistic well being. Thank you for your attention, and I look forward to the insightful discussions that will emerge from this conference and wish you all a very successful and productive conference. And I once again thank all the organizers and especially the University of Faisalabad for inviting me here as the chief guest. Thank you very much.
Thank you, Professor Syed Asghar Naqvi, for your enlightening and inspiring address. Your words have provided us with invaluable insights and have set a strong foundation for the discussions that will follow. We deeply appreciate your presence and your continued support for advancing knowledge and research. As we near the conclusion of this inaugural session, I now request Pro-Rector Professor Dr. Amanullah Malik and Conference Chair Professor Dr. Tanzila Khalid to present shield and souvenir to our chief guest for his valuable contribution and presence today. I request other guests to please join us as well.
Sorry.
None of our nation, kindly stand for the national anthem. And with that, we conclude the formal proceedings of the inaugural session. I would like to inform you that we will now take a break for tea. Respected guests, kindly proceed to the executive hall. And conference delegates, kindly return to the auditorium after the break, sharp after 20 minutes, as we resume the conference with the scientific sessions.
स्टार्ट कर दूं मैम वो कैमरा मैन स्टार्ट करूं Bismillahirrahmanirrahim. In the name of Allah, the most merciful and the most beneficent. Honorable guests and respected conference delegates, welcome back. I hope you all enjoyed the tea break and are ready for what promises to be a stimulating and enriching session. My name is Mahanur Khurram and I am the head of Publication Committee, Society for Skincare. It is my pleasure to moderate the second scientific session at the 4th International Conference on Dermal Sciences. This session is titled United for Skin Health, Advancing Sustainable Development Goal 3 with Allied Health Education. We aim to explore the role of allied health education in enabling our health systems to achieve healthy lives and well-being for all at all ages. We are incredibly fortunate to have some of the leading experts in the field of medical education with us today. To begin, it is my absolute pleasure to introduce the chair of today's session, Professor Dr. Musaratul Hasnain. He is Senior Most Professor of Medical Education in Punjab and among the pioneers in the field of medical education in the country. Professor Dr. Musaratul Hasnain did his master's in medical education from Aga Khan Medical University. He is the head of medical education department at Rai Medical College, Sargodha. He is also a PhD scholar at Ambrosiana University, Italy. Dr. Musaratul Hasnain's work in reframing health systems in developing countries has made significant contributions to the improvement of medical education and patient care in resource-poor settings. This session is co-chaired by Professor Dr. Tahira Iqbal, Dean Faculty of Medicine and Allied Health Sciences at the University of Islamabad. Professor Dr. Tahira Iqbal is a distinguished academic figure. She served University of Agriculture, Faisalabad, for more than 33 years as a teacher and researcher, guiding the research to the postgraduate students. She has published 97 research papers in international and national journals, and has also presented her work in national and international conferences. Without further ado, I'd like to introduce our first speaker, Dr. Gohar Wajid. He is the Technical Officer, Health Profession Education for the World Health Organization. He is a visiting professor of Medical University at University of Lahore, Rifa University, University of Dammam, Kingdom Saudi Arab International University. He specializes in strategic and operational planning in health services. He has the credit of establishing healthcare quality management system and organizing health information management system at United Arab Emirates. His publication ranged from the topic of professionalism to patient safety, among many others. He has contributed to numerous international conferences as a guest speaker. He is recipient of M.H. Kazi Lifetime Achievement Award from the University of Lahore. His title of talk is Importance of Allied Health Professionals in Healthcare Scenario, a focus on resource-limited countries.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Dear conference participants, and especially the leadership of the conference organizers, Dr. Komal and Dr. Tanzila, especially for inviting me and especially organizing such an important event, and especially including allied health professionals, their value and the critical role they play in providing health services to any people and in operationalizing any health system in its context, because no health system can be workable without the crucial role that is played by allied health professionals, other than, I would say, doctors and nurses. There are so many other professionals that play critical role in the overall management of the provision of health services. Let me clarify it right in the beginning that whatever the views I am expressing here, they are entirely my own views, and they are not reflective of the policies of the WHO or any institution for that matter. Now, what is the importance and the value, and especially the numbers of these health professionals and how many they are required in the country? Unfortunately, these kind of data are very difficult to collect and is usually not available. But I can give you some general idea about how many we need and how important they are. From the perspective, if we see the number of doctors, nurses, and midwives in Pakistan, we have some data available that the number of these health professionals, doctors, nurses, and midwives, is around 16 to 17 per 10,000 population of the nation. When we look at the required number for any country in terms of achieving what we call sustainable development goal number 3, that relates to the provision of health services and what we call universal health coverage, which means providing basic health services to the people. And here I'm talking only about the basic services that are needed and defined by any government. So we get to know that we need between 44 to 45 doctors, nurses, and midwives to provide these basic health services to the people. While in Pakistan, as per the government figures, we have their numbers between 16, 17, or 18 per 10,000 population. This number is so low that WHO has included Pakistan as one of the countries in what we call support and safeguard list of the countries. These are the countries which have critical shortage of health workers in terms of doctors, nurses, and midwives in the country. Pakistan, as you all know, has a population of around 235 million people, and all of them, they require one kind or the other health services. At least the minimum basic health services are the ones that is the fundamental right of all human beings. Now, in order to provide these services to the people, we have to understand the population dynamics and the needs of the communities so that we can organize health services based on population needs. We need to understand how population dynamics are changing, how the disease patterns are changing, how the epidemiology of the disease is changing, what exactly are the services that will fit the needs of the populations for which the health system and health services delivery system is being organized and developed. On top of it, we have seen that health systems are getting increasingly complex. The roles of different health professionals are getting increasingly complex. More and more new specialties are being created. There is an insurge of digital technologies that are penetrating not only the society, but the healthcare system and impacting the delivery of the system in terms of making the systems more and more specialized. Now, all these issues that I have highlighted before, they signify that there is a need for health professionals who understand the dynamics of the system other than doctors and nurses. That is where the role of allied health professionals in terms of whether they are pharmacists or they are rehabilitation experts or nutritionists or lab sciences experts or radiology sciences experts, they get crucially important in the provision of health services. So from this low number of doctors, nurses, and midwives, you can extrapolate what could be the condition of other health professionals who provide critical services in terms of joining hands with doctors, nurses, and midwives to form the teams of health providers that could provide essential services. So what it means is that Pakistan certainly needs to improve the production capacities of allied health professionals as well, in addition to producing more doctors, nurses, and midwives. Now, this is not enough and important that we have improved and increased production capacities. At the same time, it is important that whatever the health professionals we produce, be these pharmacists or rehabilitation experts or lab technologists, etc., all of them need to be absorbed as well in any healthcare system. Now, what does the absorption mean? It does not mean that all of them must be given a government job. Rather, absorption may take place either in the private sector, or it may take place in the government sector, or they might open their own businesses, or some of them might decide to migrate to other countries even for better jobs. So the demand at all levels globally, as we have seen and we discuss, is that health professionals are generally low globally. But at the same time, governments need to provide better job opportunities to these health professionals and provide better working environments and working conditions so that they can perform their roles effectively in any healthcare system. So, what is the role and responsibility of allied health professionals in the provision of health services? You can understand the value and the crucial role these professionals play that the government of Pakistan has already committed to developing the healthcare system based on the model of delivery, what we call family practice-based model of delivery. What it means is that the system of provision of health services would be based on family practice. And family practice-based system, it is provided through the development of teams. Like a team may consist of one or more doctors, including the nurses, including all other health professionals. For example, at a primary healthcare center, there could be the provision of a lab technologist or maybe a radiology technologist, certainly pharmacists or pharmacy technicians, maybe rehabilitation experts, community based like what we call lady health visitors and other professionals who provide services as in the broader spectrum we call them community health workers. So all of them, they form the part of the team in order to provide efficient and effective health services to the people of the country. So this is basically where our thought process extends beyond just treating the patients and diseases rather than taking care of the health of the people of the country. So it's not just about treating the diseases or diagnosing the diseases and writing down medicines. Rather, the concept of holistic provision of health services in that kind of the health services provision system, allied health professionals, they play very crucial roles. And in order to provide these things, we have seen that even the roles of allied health professionals, they are increasingly being professionalized. And that is primarily happening because the technologies are getting complex, the machines are getting digital and complex, and we need specialized people who can operate and efficiently and effectively run those machines to get the tangible results that are expected from those machines. So, essentially speaking, what we need to consider from Pakistan perspective is, first of all, we need to certainly improve production capacities, or at least do not lose the production capacities that we have presently already developed. Then we also need to pay attention to improving the quality of education as well. As we can see that educational systems are rapidly changing, especially after COVID-19, we have seen inception and more penetration of digital technologies. Then the governments need to improve the employment capacities so that whatever health professionals are being produced, they can be better absorbed in the system. We need to pay attention to what we call skill mix, which means that with ratio to the doctors, we just don't need to focus on producing doctors. Rather, we need to focus on producing other health professionals like nurses and pharmacists and dentists and other allied health professionals that are crucial to run any system. They should be produced in a balanced skill mix so that they can become an effective part of the healthcare system in order to provide health services. And when it comes to other levels of care, for example, secondary, tertiary, and quaternary care, we have seen that these specialized hospitals that provide advanced level of care, they are practically not possible that these hospitals can be run without the services of allied health professionals. So I have addressed the value and significance of allied health professionals at the primary care level, where there are huge gaps and big demands of these professions, and at the secondary tertiary levels, advanced levels of care, where they are very specialized health professionals that are required as essential components, integral components of the teams that provide health services in these tertiary level institutions. So certainly there is big demand in Pakistan and globally, but there are certain precursors in order to succeed. What we call excellence is the key to success. Mediocrity may not lead to success. So I would urge that all of you, provided you are excellent and you excel in your fields, there are always demands for excellent health professionals, not only within the country, but at the global level. So I wish you every success in your life and future endeavors. And I urge that all of you should strive for excellence to achieve your lifetime goals, ambitions, and targets. May Allah bless us all. Thank you so much.
Dr. Gohar Wajid, thank you for the thought-provoking presentation. Your insights on governance and leadership in medical education will undoubtedly inspire our approaches in health sciences. Next, we have Professor Dr. Masratul Hisnain with us. His title of talk is Advancing Sustainable Development Goal 3 through Reframing Health Systems in Developing Countries.
Bismillahirrahmanirrahim. Assalamu alaikum. I feel honored to be here with all learned people around me, and it's a great opportunity for me to learn from all of you and share my thoughts about this conference, the theme of the conference, which says skin connects. I would rather add to it. Skin not only connects, but it also protects. It is a coverage for everything. And in that way, symbolically, it is with the concept of universal health coverage, which is theme of the SDG 3 of United Nations. So all things together tell us about the importance of skin and its far-reaching effects on human health. Professor Asr Naqi talked about scarring, and that was physical scarring. And talking about colorism, if you think deeply, if one is too much indulged in colorism, the victims get psychological scarring. And that scarring is even more detrimental than the physical scarring, what we see on the face. Today, I'll share few thoughts about achieving Sustainable Development Goal 3 through reframing health systems in developing countries. Goal 3 states that good health and well-being ensure healthy lives and promote well-being for all at all ages. That's very important, that it should be for all, of all ages, in that way, universal health coverage. If we look at the health systems, they are primarily designed in the cities, in urban areas. While most of our population, out of 235 million population in Pakistan, about 70% they live in villages. I come from the village, so I know what are the hardships over there. Many years back when I graduated and my father wanted me to serve in my own city, which is an underdeveloped one, I was convinced that my favorite subject, which was psychiatry at that time, would not help me serving those people in underserved area. So I had to force myself into surgery. You know, here lies the difference. The needs are different. And I tell you, my observation is that all the people who are involved in planning about health systems in underdeveloped countries, they know nothing about the context of rural areas. Just to let you understand, I would tell you a scenario. If a doctor, and Professor Akmal Saab is sitting here, he would be with me about this observation, that if Professor Saab asks a student and the student or the doctor, reaches at some accident scene and there are many people injured over there, and some person needs the doctor the most while we do the triage, there would be some kind of management if you ask in the exam. And that person, the doctor will tell you that kind of management. And if the same person, same injured person is brought to the office in the hospital and the same doctor is sitting there, so I would ask you, sir, would the management be same? No. And if you are scrubbed already and sitting or working in the operation room, the same person is brought to you, the management will still change. And that would be entirely different from the management at the accident scene. So everything depends on the context. It's the same doctor, same patient, but the management changes. And unfortunately, there is no evidence collection in the rural areas in the form of research. So people who are developing different plans, planning the health systems, do not know nothing. So we need to establish some system of research, some system of understanding the fate of these poor people who are struggling with the sustenance of life rather than quality of life. Majority of us. So we should think about them. In that way, as Professor Gaur Wajid told us, that the importance of allied health professional is even greater in our country than in any other country of our region. This is where we are. You can see this is the scene over here. Universal health coverage. And this is the practical view. As I come from the village, I do understand it. In order to learn or understand about a word, you have to experience it. Munir Niazi, harf, ek duje harf da parda. Harf, ek duje harf da parda. ਤੇ ਮੈਥੋਂ ਕਿਆਸ ਨਾ ਹੋਇਆ सारी हयाती हर्फ लिखे पर हर्फ शनास ना होया। जब भी कोई आप लफ्ज सुनते हैं तो जब तक आपने उसको एक्सपीरियंस ना किया हो आप उसका मतलब नहीं समझ सकते। हमारे एक अजीज थे, लॉयर थे सरगोदा में, उनकी वाइफ का इंतकाल हुआ, बड़े मशहूर लॉयर थे। आई विजिटेड देयर आफ्टर 15 days। तो वहां वो बैठे थे तो उन्होंने कुछ कहा और वो मुझे आज तक याद है। उन्होंने कहा कि मुझे 30 साल हो गए वकालत करते हुए और हर रोज 30-40 बेल एप्लीकेशंस लिखवाता हूं और हर बेल एप्लीकेशन की एक ही इबारत होती है जिसमें एक फिक्रा बहुत जरूरी होता है और वो ये है कि अगर साइल की जमानत ना ली गई तो साइल को नाकाबिले तलाफी नुकसान होगा। कहते ये फिक्रा मैं हर रोज 30-40 मरतबा पिछले 30 साल से लिख रहा हूं। वाइफ के इंतकाल के बाद आज मैं पहले दिन कोर्ट गया हूं, पहली बेल एप्लीकेशन लिखी है तो जिंदगी में पहली दफा इस लफ्ज का मतलब समझ आया है कि नाकाबिले तलाफी नुकसान किसको कहते हैं। दिस इज हाउ इट चेंजेस कि जब तक आप एक्सपीरियंस नहीं करते आपको उसका पता नहीं होता। एंड अनफॉर्चुनेटली जो शहरों में हैं वो रिसर्च जानते हैं, जो देहात में ऑलरेडी काम कर रहे हैं, they are too much overwhelmed with the service and they either do not understand or do not know the ways to research or they don't have time for that. So result क्या है? No evidence is coming from the rural area. तो सारी प्लानिंग अर्बन की हो रही है। तो ये एक बुनियादी पॉइंट था जो मैं आपसे शेयर करना चाह रहा हूं और ये आप देखेंगे दिस इज द डिफरेंस। Healthcare challenges faced by people in rural areas of developing countries. All these have been collected from the evidence, and this evidence is not sufficient, I would say. The matter is too far reaching than what you see on this board. So just looking at it, lack of health workers is at the top. Professor Gohar Wajid already explained this. Less attention in providing healthcare services, delay in accessing emergency obstetric care, immunization accessibility, the rising cost of health services, the burden of communicable and non-communicable diseases, lack of transportation facilities, and after this surge coming up in the rates of fuel has even complicated it more. Now people can't afford to go to the cities. And then lack of clear priorities, lack of adequate planning mechanism, and inadequate health education. So all these factors are, to sum up, make the things rather impossible for the rural area people to get an access to the quality health care. But they don't even ask for that. They ask you to provide an environment in which they can breathe. So first target should be let them breathe. You see, rural crossing, one is rail crossing, this is rural crossing. And what happens afterwards is that you are on your own. After you cross this, you are on your own. Nobody is there to help. Doctors want appointments in the cities, and still they complain that our positions over there may not be fulfilled by allied health sciences. So what to do with those people? And if my colleagues in dermatology, if they permit me, our orientation in dermatology nowadays is towards cosmetology, only because it is more rewarding. So let allied professionals help people with the basic diseases of dermatology in rural areas. You don't want to let them serve as well, and you don't want to go there as well. So this is a dichotomy which I see here among our respectable colleagues. In Pakistan, few statistics here. Population is 247 instead of 235. Current health expenditure, which is very, very unfortunate, is worse than any other country in our region, in Amro region. And you know this, that our country falls in South Asian area, but WHO has put us in Amro region only because of political reasons. We were not influential enough to, bring us in that area where the attention of WHO should have been more. There's so diverse population, so diverse countries are there in Amro region that we get least attention because of the area distribution. Then World Bank income level, lower middle income. Life expectancy at birth. So these are two different concepts. Life expectancy refers to the number of years a person can expect to live. It is an important way of assessing the health of population and is used to inform health policy and initiatives that impact everyday life. Life expectancy at birth is every number of years that a newborn could expect to live. In Pakistan, life expectancy at birth has improved by 5.91 years from 60.1 to 66 years in 2021. And Eastern Mediterranean life expectancy at birth has improved by 3.47 years from 65 years in 2000 to 2021. What does that mean? Apparently, it looks that we have improved more than the region. But this is the play of statistics. We are standing at the worst countries. But collectively, when they measure those countries with us, then the situation differs. It differs. Healthy life expectancy at birth has improved by so many years, 4.54, and in Eastern Mediterranean it has improved by 243 years. तो कोई जो आपको इमदाद देने वाला होगा वो क्या सोचेगा? आप तो बहुत तरक्की कर रहे हैं. So it's relative. The context matters. Top causes of death in Pakistan. You can see ischemic heart disease, stroke, preterm birth complications, birth asphyxia and birth trauma, chronic obstructive pulmonary disease. Then is lower respiratory tract infections, diarrheal diseases, diabetes mellitus, congenital anomalies, and tuberculosis. Population growth rate. It is one of the highest. Would you believe that every minute we have addition of 6 more people? And if you want to educate this society, the population of 247 million people, you need a new primary school. Even if you want to educate them to the primary level, you need a new primary school every 20 minutes. Is it possible with our existing resources? So the pyramid is taking a different shape. People who are educated, they have little number of children, they get them educated, and the people who are uneducated, they are giving birth and raising those children who are uneducated, and that size of the spectrum is increasing day by day. So situation is getting worse. What is health system? As I've talked about health system reframing. So what is health system? Health systems can be understood in many ways. The WHO defines health systems as all the organizations, institutions, and resources that are devoted to producing health actions. So whatever health action is there, all the organizations involved in that, they form the health system. The definition includes the full range of players engaged in the provision and financing of health services, including the public, non-profit and for-profit private sectors, as well as international and bilateral donors, foundations and voluntary organizations involved in funding or implementing health activities. Health system encompass all levels, central, regional, district, community, and household. Health sector projects engage with all levels and elements of health system and frequently encounter constraints that limit our effectiveness. The World Health Report 2000 identifies the 4 key functions of health system. One is stewardship, often referred to as governance or oversight, which is done by the government. Then is financing. Then is human and physical resources. Then organization and management of service delivery. So these are the 4 key functions of any health system. And here they have their own relationship with each other. Here we have delivering of services. You can see this. And all these are required for delivering these services in the health system. This is just to let you know what is happening around the world regarding allied health professionals. There are definitely practicing categories like physician assistant, nurse practitioner, and here you can see Mayo Clinic College of Medicine and Science. You can see that what they are doing. Physician assistants are licensed medical professionals who provide direct patient care as a critical member of today's team-based care, physician assistants diagnose illness, develop and manage treatment plans, prescribe medications, and advise patients on optional health practices. Maybe on showing this slide, the whole medical fraternity goes against me. But the ground realities should be considered, and overall welfare of the country and collective welfare should be in front of us. The way forward. There are many systems working in this world, and the system I like is that of Iran. I've been there, I've observed their system. We were invited by Tehran Medical University, and they got us visit all the different integrated services they are offering. And their model is what I present to you. This is the model. Suppose this is a government university, then government university Faisalabad, like the University of Faisalabad, is in charge of all health services of Faisalabad division. And the chancellor, vice chancellor over here heads all the institutions giving health care in whole the division. So it is so much integrated. You can see Ministry of Health and Medical Education, then University of the province, then district health network under him, schools under him, teaching hospitals under him. Then district health network has district health center, which includes rural health center, urban health center, health post, health house, district general hospital, schools. Now imagine if the data is constantly registered at the root level, as Professor Gaur was saying, the family practice orientation of the health system, then you do not need to explain many things to the doctor you are going to see. It would be integrated. A person sitting in my village sees the doctor over there, and doctor is directly connected with district headquarter hospital and then finally Medina Teaching Hospital. So all the facilities which are available all over the division, they are available to the person sitting in my village. In this system or in this model, what is the duty of the universities? Universities have their social responsibility and social accountability. So if they want to take their head off social responsibility, I, being citizen of Pakistan, will get hold of them in the form of social accountability. They are answerable. It is part of their job. So what I suggest is, if the government universities don't wait for the orders of health department and they establish their own connections in the district level with the rural health center, with the basic health, they've organized and they make a system. And the same way, the University of Faisalabad makes some centers in the rural areas which are directly connected with this, or in the new wave, when the government is trying to privatize the rural health centers and basic health units, I would suggest that University of Faisalabad should try to get those centers equally distributed in the division of Faisalabad, get them connected. I assure them that it will not be a big financial concern because they'll be self-producing their own and self-sustaining model. So I would, with this forum, I would request the University of Faisalabad to think about it and try a basic plan. I, being a small person, a worker, offer my services free of cost to the university to develop a system of integration in the health. In the end, just a scenario our respected Chief Minister has created for us, that is about the doctors on wheels. So this is how they work. You can see doctor on wheels, and they are serving the people in the country. So both points, some people take it healthy, some people don't take it healthy. I won't comment on that. But this is the situation. And finally, it ends. Okay. Another suggestion is that if the university finds that they do not have enough funds to own or adapt those centers, they can at least start with the research in the rural areas. They provide their expertise and then engage some of the researchers who do not require a lot of money to get involved. Now you have many doctors available, and get the direct evidence from the rural areas to make people or planners understand what is happening over there. Thank you very much again for this kindness, for this honor given to me. And I wish this university grows. And I'm again thankful to Professor Tanzila. I've always learned from her, and we have been together now for like, I don't know, maybe for ages. Thank you very much. Okay. Very,
Thank you, Professor Dr. Maseret Isnan, for sharing your profound knowledge. Your work truly broadens our understanding of remodeling of healthcare system, reminding us the importance of continuous learning in healthcare system. It is now my pleasure to introduce Dr. Noor Kiran, Health of Medical Education Department at Ebba Medical College, Faisalabad. She is a well-known medical educationalist, digital learning strategist, and facilitator, in addition to be a sub-fertility consultant. Dr. Noor Kiran is dedicated to integrate artificial intelligence in medical education, pushing forward innovative approaches to improving medical outcomes and research. Her title of talk is Integrating Artificial Intelligence in IPE and Research.
College. Apart from that, I am also an enthusiast in infertility treatment, doing my challenges and helping patients with infertility in my own setup in Goja, as well as I am also an online virtual learning caster, and I take pride and honor to help and support online learners in different kinds of courses and the webinars and workshops that we arrange. I am today extremely thankful to the University of Faisalabad for inviting me over to share my views about this really important concept that we have all witnessed for the past 1.5 to 2 years. And now it's time that we start thinking about how to integrate artificial intelligence in interprofessional education and research. So what would be the way forward from the fact that now we have all been oriented with the concept of artificial intelligence? We can all relate that it's only around 2 years now, since November 2022, that we got to know about this ChatGPT, artificial intelligence, large language model, generative predictive transformers, machine learning. And within some time, we understood that the role of artificial intelligence in healthcare education and clinical practice is so vast and the future is so promising that it would take me the whole day if I keep on talking about it. Overall, if we talk very technically, that I would emphasize on the point that in healthcare alone, artificial intelligence has so much role in improving the diagnostic accuracy and enhancing it and reducing the time and the energy used by the pathologists or anatomists or dermatologists, for example, radiologists, for diagnosing a disease. And they can use different AI tools for diagnostic accuracy. And when we talk about this point, that this would eventually lead to patient safety, it wouldn't be fair if I do not mention that these would actually should be inculcated in some sort of a curricula in which student can be oriented beforehand they enter the practices and real world example. And this could only be possible if we integrate the artificial intelligence into training in the biomedical curricula into interprofessional education. And when we talk about how to do that, I think it's time for us to join hands with the IT segment, with the computer segment, so that the healthcare professionals and the computer science departments, they can form a multidisciplinary approach to form a holistic positive learning experience for the student and prepare them for real world healthcare applications. So this is just an example of how artificial intelligence has influenced simulation-based study. We ourselves are very intrigued and we are inspired by simulation-based learning, and we couldn't think there could be anything else that could happen over here. But even in the simulation-based learning, which is itself an innovative form of learning, artificial intelligence has proven to have a very positive role in impacting the learning outcome, increasing the engagement rates of the student, increasing the collaboration skills of the students, and even allowing the teacher to have a more precise feedback to the students. Overall, with artificial intelligence, with all these skill developments, there have been a cost reduction in training and time savings. So when we take, okay, no, it's all right that simulation-based learning, we are already doing it. So why would we use artificial intelligence in that? And so my point is that even that innovation can be enhanced by artificial intelligence, and the talk doesn't stop over here. When we focus on interprofessional education, there are multiple studies which have been conducted. There is so much work being done in the Western world, and they have noted a rate of 65% of the institutions incorporating artificial intelligence in some form or the other in undergraduate education. And out of these, 40% AI has been used for realistic scenario creation. The students are also have been reported to use as well, and their confidence level has increased by 25%. These institutions, they are providing these students personalized learning pathways in 35% of the cases. And even in the research segment, there has been research engagement increase by 30 to 40%. These are only just a little stats to let you know that the world is moving towards using AI in interprofessional education. And we are not, the time is not far behind that we would also be in the same routine. So, like I already said that there are multiple benefits of integrated AI in education, and then there would be benefits and applications of using AI in clinical practice. So, in education, the artificial tools can lead to enhanced learning, improved accuracy, data analysis can be done, They can be used to have automation leading to time efficiency. Patient engagement can be done by maintaining their health via different AI apps, and overall, it could even lead to collaborative care. So, what about in clinical practice? Overall, clinical practice revolves around diagnostic supports, laboratory automation, process automation, different rehabilitation technologies are over there. Patient monitoring and patient healthcare devices are already there, and it can further, artificial intelligence can further enhance. So, in diagnostic, radiology can help interpret different medical images. Histopathology can help in interpretation of different slides, and there are multiple applications now available. A lot of work has been done on histopathology and understanding the pathological pattern by the AI. You can always look around and you can see there are multiple papers you can find in the domains of pathology as well. So people ask me how to go about it. How can we further move forward? So in an institution where we are having interprofessional education, we would have to redefine the level of integration of artificial intelligence in our setup. And this would definitely be influenced by the HEC AI policy or the global artificial UNESCO AI in education policy, which can help us guide. And depending on our resources, we can further move forward. A quick example would be that the institution is visioning to revolutionize healthcare education through the transformative integration of artificial intelligence across the discipline. Mission could be to empower the healthcare professional, and how to empower? To have a collaboration, innovation, integration, and excellence. So we can start off by preparing the graduates for AI-driven landscape via curriculum formation, via collaboration, ethics, and research. And this is how we begin. There is a lot of optimism, but there is also concerns. Many strengths are there. This is the time. The opportunity is even better. That this is the time we can. Everyone is pumped up and everyone is excited about AI. We can do it. However, our weaknesses do lack that we currently do not have that kind of a knowledge. That is why I'm saying we need to have collaboration with the computer sciences department, and we have limited faculty expertise for training. Threats might include different ethical violation, data privacy violation, but within an institution that can be catered to have a very closed circuit for these data driven analysis that an institution does. It can limit the provision of data further forward. One proposal may be to develop and identify the AI competency related to your students, and to implement evidence-based curricula with evaluation, resource sharing for curriculum development, engaging all the stakeholders, the teachers, the students in the curriculum design, so that you can understand where we all do. There is a world of, now is the world of co-creation. We need to step forward and also allow our students to give input in the curricular formation. Finally, we align how much of the industry is aligned with the AI education outcomes that we are providing. Ethical consideration should be done, and fostering interprofessional collaboration among education. And finally, continuous assessment, monitoring, and evaluation for curriculum improvement should be done. Different models are there. One can adopt multiple models starting from the foundational AI concept. Only the undergraduate curriculum could have a foundational AI. Further, it can be further enhanced that you are allowing students to use various AI tools in different educational subjects. Further enhancing, you can even ask them to do collaborative learning via AI platform, and you can include artificial intelligence tools in the assessment, in the research as well, and finally the AI leadership across the discipline with the interprofessional education. So overall, the integrating AI into interprofessional education would involve a holistic curriculum development, faculty training, developing ethical framework, having continuous assessment and evaluation, all with the help of interdisciplinary collaboration. So AI competency needs to be identified. We need to know what are the AIC artificial literacy skills that we need to develop in the start, along with the ethical consideration. This is again the standard core competency. You can have above 2 or all 4 of these: AI literacy, ethics of AI, data management, interpreting AI insights, and much more. A proposed AI coursework can have, for example, can have some work on the data science, statistics involved over here with real world biomedical example, with the ethics of AI, health informative collaborative learning. Challenges would remain, but challenges can be overcome. They are there so that we can find a solution for them. So faculty training is over there. There are students of different diverse background that we need to consider. We don't have the finances at times. There are financial constraints. So we need to look into this as well to develop a model which is suitable for our context and institution. Curriculum overloading, already the students are overloaded. However, if we somewhat integrate AI so that their workload becomes easier, so it would be a good option. And finally, ethical consideration needs to be thought about. For the policy development, I think we should start with the policy framework leading to faculty development, then the curriculum design, and then the implementation with collaborative learning following the ethical standards. So the institution needs to develop clear guidelines for AI use in healthcare settings. And to overcome these barriers, we need to build trust among the team, and we need to develop resources, continuous feedback, streamlining different collaboration. Future direction may be pilot programs may start, then feedback is integrated next year, then wider adoption and further expansion of research and other comprehensive programs going on. These are just the AI consideration of data privacy, informed consent, bias mitigation, transparency should be there, and continuously training should be held. The governors who are involved in AI implementation should make sure that the data is protected, the ethical guidelines are being followed, interdisciplinary collaboration is supported, and ongoing training of all the stakeholders are being done. And finally, with continuous training and data integration, we can have a very best practice in AI adoption and leading to enhanced student outcome, which we can measure via different feedback mechanism for continuous improvement. In conclusion, the call of action would be that we need to enhance, the AI can enhance the learning outcome and drive research innovation. It can streamline administrative tasks, foster collaboration, improve assessment techniques, and prepare future professional. This is our duty, that we prepare the future professional by using and equipping students with the AI knowledge. For that, we ourselves have to train ourselves and get ourselves trained to have a useful use of artificial intelligence in healthcare professions. I thank you once again, and thank you so much for having me here. My apology for not being here in person due to a emergency commitment that I had at my workplace. I wish you all the best. Any questions are welcome. That would be given. You can email me. You can give it to Dr. Tanzila. I'm especially grateful to Madam Komal so that I can answer your query. Thank you so much. And Allah Hafiz.
Director, Department of Medical Education, University Medical and Dental College. Over her career at UMDC from 2016 to date, she has received many awards, nominations, and accolades. Dr. Komalata's work focuses on enhancing communication and collaboration among health professionals for better patient outcomes. Her title of talk is Skin Deep Connections, Uniting Allied Health Professionals Through Communication.
Assalamu alaikum, everyone. My name is Komal, and today I will be talking about a very important topic related to all of us, that is skin deep connections, uniting allied health professionals through communication. So, before we start with the main crux of the talk, I'd like everyone to just raise their hands if you've worked with other medical or allied health professionals in the last week. Those who are online can do it on the Zoom link. Okay, thank you so much. Now, raise your hands if you've had to clarify your professional role to another team member. So, you see, a lot of us face communication gaps on a daily basis. This is the main theme of the talk today, that how to develop skin deep communications and how to actually communicate properly about the roles of different professionals so that they can work together peacefully. Here is the outline of the talk. We'll discuss briefly what interprofessional education means. Then we'll move on to the concept of skin deep in health communication. We'll see how we apply it. We'll discuss a case study, and then we'll see evidence-based strategies of communication skills. And we'll move on to see how practically we can do them, what are the problems that we will face, and how we go ahead with them. So, interprofessional education mainly means any type of collaborative, meaningful, combined work between people of different professions. So, in the realm of health professions or healthcare, we cannot work as a single entity. We have to work as a team. So, if you are an aesthetician, or if you are a dermatologist, if you are a medical health professional, professional educationist, if you are a surgeon, we all have to work together. There's no single slot for one of us who can take the baton from anybody else. So we all need to work together, and we all need to work according to our defined roles in a professional, proper, structured manner. Now, the concept of skin deep. The concept is basically inspired by this conference, which I have had the wonderful experience of seeing since its inception. And this year, the theme was Skin Connects. So, what I realized was that skin is, of course, it's the biggest organ of the body, but it's not something which is just on the surface. It is a lot like communicating, that it protects your deeper layers and then it helps you foster your health overall also. So, similarly with communication, as you all know, that there are different layers of the skin. So, there's the dermis, the epidermis, and the lower layers. So, similarly, communication is also multi layered. There is superficial communication that we have with each other on a daily basis. Congenially, we meet our colleagues, we say salam, we say our goodbyes. Then there is an intermediate level of communication where we will foster understanding with each other. So, if you are working in a clinical setup and you feel that you cannot communicate with the dermatologist you are working with as an esthetician, or you feel that you cannot communicate with the lab technologist or with the scrub nurse, that is where problems begin. So that is where we have intermediate communication, where we want to create some sort of link with all of these people to finally foster deep communications that are necessary for working in a team. You cannot work in a team together unless you trust each other. And that only happens with proper, impartial, head on communication skills. So, trust के लिए क्या implications है? It is basically effective communication across all levels, which will lead to trust. And that will lead to stronger patient outcomes, which is the main purpose of all healthcare professionals. All allied health sciences, all medical sciences promote this and this only, that we need to work for our patients. Now, let's go towards an example. There is friction between different professions since the beginning. You may have noticed in your professional identity that being students of dermal sciences, being students of aesthetics, You might see a sort of gap with the dermatology community or a gap with the surgery community. However, you have to understand that we all have to work together. So this is just a case, for example, if there's a physiotherapist. If the physical therapist has not properly communicated well with the radiologist, they send the scans, the reports were not properly communicated. The physical therapist could not read the exact problem that was going on. And what happened was that he could not treat the patient properly. So he jeopardized the patient's safety just because he was reluctant to talk to the radiologist about the actual issue. So the problem going on over here is that we think we can do everything. We cannot do everything. Everybody has a role. Alternatively, what happens if they had regular team meetings and they had collaboratively designed a customized plan? So all the rehabilitations of the patient who was fractured severely could easily have been taken place. If the physical therapist was collaborating with the surgeon, with the radiologist, with the nurses, things would have been much different. So you see, communication is not something that we teach or something that's a part of good behavior. It is the essence of patient care. So unless and until you communicate effectively, you cannot prove your mettle, particularly as an allied health scientist. You have to communicate with your physician friends, with your doctors, and make them understand that this is my domain. These are the things that you will need from me. And similarly, they will communicate with you. So ideally, how do we apply skin deep communications? Taking the same scenario of the physical therapist. So the first thing is initial dynamics with your other fellows. So initial dynamics में क्या होता कि जो physical therapist है वो radiologist के साथ बात करता, उनसे request करता कि जी मुझे images share करें. The radiologist would have shared the images, they would have talked to each other, come to some sort of an arrangement. Then they would recognize common goals. This is very important. We do not threaten each other. We have to understand that we are working together as a team. If you are an esthetician or a student of dermal sciences, think about the common goal you have with dermatology. That is treating people's skin. So when you come to the common goals and put the differences on a side and negotiate with what each of you can do, the communication grows stronger. And that is the way you will be able to excel forward in your clinical specialty. So again, if the physical therapist now sets common goals and both of them focus on the patient's rehabilitation and further recovery, it becomes easier for the radiologist to also understand the physical therapist as a health professional. Finally, there has to be iterative collaboration. They have to talk to each other, there has to be feedback, they have to link with each other continuously throughout the process till the time they are treating the patient. So skin deep collaborations have these three things: establishing immediate dynamics, coming up with common goals between your professions, and then collaborating with each other continuously. So we will discuss the issues later on that why we don't do this, but this is actually the essence of how you can define your community and how you can defend your community. So structured communication has always been beneficial. Research has shown it over multiple years, multiple papers, that if you have planned your communication skills in the clinical setup, that really helps in developing teams and it helps in the growth of allied health professions. And it reduces medical errors significantly. Now, here's a basic framework for clinical skills. There are three main things. The first is active listening. We usually practice these things with patients. So active listening means that you understand the patient's needs, you try to involve them in decision making, you try to listen and look for all sorts of signs. You have to do the same with every member of your team. If you are with a technician, if you are with a nurse, if you are with a senior doctor, if you are with a junior doctor, you have to actively listen to their component, and you have to actively understand how can they function in this team to help you and to provide better care for the patient. The second thing is empathy. So empathy is basically looking at somebody else through their lens by saying, you can say that it's like being in someone else's shoes. So if you can empathize with the other person on your team, if it's a nurse, if it is a technician, and you think that if I would have been in her position or his position, this is what I would have been going through. This is why I'm not communicating. This is the problem. Then you can actually have better teamwork and better skills. The third thing is Cobb's experiential cycle. So, because there has to be some component of medical education here, so this is the theory part. Cobb's experiential cycle basically is a cycle that defines how we look at an experience. And different studies have actually advocated the using of this cycle in interprofessional education when different healthcare professionals come together of allied health sciences, of medical sciences, of dermal technology, dermal scientists, when they all come together. So they have to look at patient care as a collective experience. So, what the cycle says is the first thing you do is obviously there is an experience there. So, you're doing or having a concrete experience. You reflect on it. Reflect on it with your team. Reflect on it with all the members. See the challenges that you are facing. See the challenges that the dermatologist is facing, the challenges that your nurse is facing. So, once you have everything in perspective, what is good, what is bad, how can we help, what are our limitations, then you move to the next step. That is conceptualization. So, conceptualization is basically learning from what has just happened. So, there's an experience. Let's say there was a burn patient, and after the patient went through surgery, he's in rehabilitation, and he has developed some sort of blistering on the skin for which the dermatology department is also involved. And you, being aestheticians, are working with them also. So, that whole experience has taught certain things to you: what to do, what not to do, who to talk to, in what manner, what are your limitations, what is your job description. So, all of that comes in this part, that is conceptualization. You make a concept from this experience, and then you plan out that if something similar happens next time, how will all of us react as a team? So, this cycle works individually in learning, but it is suggested by experts of interprofessional education to use it together with your senior and junior colleagues, whoever is working in your unit as a team, whether that is at an aesthetic center, that is at a burn unit, that is at a hospital, it is at an OPD. Try to visualize your whole team together in this cycle. Now, other evidence based models exist for communication skills, particularly for allied health scientists. There is a lot of literature that reports that because of professional identity challenges, due to clashes in technical skills, for example, optometrists and ophthalmologists, dermatology and dermal scientists, aestheticians, cosmetologists, and dermatologists. So there's a reluctance from these allied health specialities to communicate with physicians, general surgeons, and people from the general medicine community. So, for such cases, if you have to work together, there are structured communication skilled strategies present. So, the one that is most commonly used and most strongly advocated by physician assistants and nurses, it's also used otherwise also, is SBAR. So, what happens in this is that if you are working with somebody else, be it a surgeon, be it a dermatologist, anybody else, you have to communicate effectively. So, if you've seen a patient or if you've seen a situation, the first thing you will do is go and describe that this is what has happened. Be as clear and as brief as possible. That this is the type of rash that this child is presented with. It has been there for 5 days. He has been taking these medicines and he's here today with a fever. So be concise, give all the details you have, and let it go to the other person. B is for background. Any other background you have, whether they have seen the child before, there's been anybody else there, give that detail also. Then is assessment. Now, assessment over here in teams, when you are working interprofessionally, it's not just assessment that you have done. So you will share your opinion or your assessment, but you will look and listen to the assessment of the other team members also. So if you are assessing somebody, as a dermal scientist, maybe the surgeon is assessing something else. Maybe the nurse has picked up on something else. So all the components have to be discussed over here. This assessment means a thorough physical examination and discussion of the case, and you have to be open to share basically. That is where the main problem comes, that we don't know or we don't want to share things. Last is recommendation. So now here you can give your suggestion based on your expertise, that based on this particular condition, I suggest that we give this patient antibiotics, and then later on we give a trial of steroids. Now this is your suggestion. It's not a hard and fast rule, but based on where you stand, this is what you have given. The dermatologist might take this and move it forward or enhance it more. The surgeon might actually suggest another intervention. So when you are working in a team together, you have to take all these things together, but key kya hai, that you have to communicate. The problem begins when we stop communicating, thinking that these people will not value us, or that we are better than them, or that we can communicate but about things which are not in our domain. So that is another thing that we have to remember, that in effective communication, we have to know what to say and where to stop. So how can we actually do this or practice this before we go into the clinical scenario, or when we are not actively in patient care? You can do role play scenarios where you can act as a nurse, somebody else can act as a physician, somebody else can act in a different position, and all of you can try to work on a complicated case together. You can have somebody act as a patient who is difficult, who is not being handled by you, where you need help by maybe a male colleague, maybe where you need help by a senior colleague. So different sorts of practices can be done to prepare for reality. Secondly, have realistic feedback mechanisms. This is very important. We need to be prepared to listen to other people, even if they're not going to say something we like. So if you have had a degree and you have specialized and you are working in a clinic, but somebody who has an experience of 20, 25 years looks at a patient and just picks up on the disease, and you're standing there and thinking, इन्होंने तो history भी नहीं ली, इन्होंने तो clinical भी नहीं किया, इन्होंने तो ये भी नहीं किया, ये क्या करी? So you have to understand that there is a difference of experience, time, energy, investment, and you have to acknowledge that. And you have to listen also. At times, feedback is not always nice, but you have to understand that you have to take things with a pinch of salt, and you have to give feedback yourself also. And you have to know that feedback is bilateral. So when you are replying, how are you going to reply? What are your limitations? You have to communicate your problem clearly, but not disrespectfully. That is one of the issues that comes when we have allied health science councils coming up, that there are tussles between medical professionals and allied health professionals, but sometimes we tend to go over boundaries of respect, and then things are lost. Technical things are lost, and there's a discussion between how a certain field is much more rude than another field, and how somebody just wants money. So these things, they come up when you don't know how to properly talk to people. So understand that feedback has to be imperative. Make a culture of feedback. Ask your technician, your junior, your senior, what they thought about when you saw a patient. Ask them about what they think about your conduct. Be prepared to listen and then give your feedback also. Now, problems that come. Why do we fail to communicate? The first is unclear roles. This is the biggest problem. Most of us are wearing many hats, and we take all of those hats with us everywhere. So you have to understand that when there's a situation where a person's life or his well-being is involved, you need to know exactly which hat you are wearing. So you have to know your limitations. Even if you think you are very capable, you are very good at performing injections, you can give injectables, you can do a surgery, you have to know your job description to the exact level. I will give, because I have more experience with optometry, optometrists cannot perform general surgical procedures that ophthalmologists can. I have students who are very, very good. They know how to do stitches. But we have to clarify it to them that this is your job description. You have to stay within it when you are in a team. So the part which the nurse plays, you have to give it to them. Let it go. The part which your senior doctor plays, give it to them. The part which you have to be very, very clear about the hat you are wearing. Sometimes what happens is that we think that because we can do all of it, we should do all of it. But that's not how it works. It takes a toll on your mental health, it takes a toll on your physical health. So you have to understand that be within your defined limitation, and God will give you more in that. Second is time constraints. Everybody is running. So we all are always out of time. The biggest problem is that we need to compartmentalize and understand what is important, what is urgent, what is not important, and work according to that. Be mindful of your timings. You cannot leave a patient emergency and go and do something of your own leisure. So you have to compartmentalize because this is a very demanding field. It takes most of your time and you have to come with that commitment. The third is hierarchical barriers. So this is also one of the biggest issues we face. We are a collective society. We have hierarchical barriers since the time we are born. So we are supposed to go through layers of respecting, and there's a patriarch at home, and then there's a patriarch taking care of everything. That goes beyond that also into your hospital settings. Also, you have very strong developed hierarchies. So learn how to navigate that system. You cannot just condemn a hierarchy. You have to learn how to communicate through the layers and get your problem to the effective level. Try to communicate with your immediate senior. Try to communicate with your boss in an effective, clear, and respectful manner. If you think that you cannot approach the head of the department, or if you cannot approach the owner of the clinic, try to communicate at all other levels where you can best manage. And what will happen is that after some time, those hierarchies will keep on dissolving and this pole will keep on coming down, and everybody will almost be at the same level and you will easily be talking. So leave that hesitation behind and make your proper mark by communicating effectively. Now, establishing communication norms, like I said, that we have to understand that unless and until we talk to each other, things won't get solved. So make it a point that you discuss cases, you work together, you work effectively in teams. When you come to an institution or a clinic or a hospital, you are not one person against the hospital. You have to understand that you are the hospital. So you have to work with each and everyone. Make it a norm that you talk to your nurse, not just when you see her in the OT. Talk to her, meet her, try to understand human communication, make it part of your culture. Feedback loops, we already discussed that unless and until we know and respect the importance of feedback, we will not be able to move forward. So, the more feedback you allow to be given to yourself and you give respectfully, the more you will grow in your own field. And the lesser you will have questions and queries about what you are supposed to do, what you are not supposed to do, why is this happening to us, why did we do this. So, it all comes down to allowing yourself to be a little vulnerable, letting other people talk, listening, and then talking. And the last thing is cross training programs. So cross training programs are basically they're based in literature, and they talk about how you can have faculty development, simulation exercises, and different sort of written and practical exercises through which you can communicate with each other. So, like I said before, there could be role plays, there could be some sort of clinical scenarios, there could be some sort of simulation through artificial intelligence, like Dr. Noor mentioned a few. So you can do all of these things to develop your centers properly, to prepare for effectively communicating with each other and with patients and with any future colleagues that you will encounter. So that is basically all. What the main purpose today was that the theme of the conference is Skin Connects. You can only connect if you communicate effectively and you develop more than skin deep connections with each other. Thank you so much. If you have any questions, I'm here. And thank you all for attending and being patient with us. Thank you.
Dr. Komalata, thank you for your inspiring presentation. Your focus on education and innovation in healthcare is essential for the advancement in skin health. We appreciate your insights and the practical applications they hold for all of us. Our final speaker is Ms. Atya Anwar. She is proud graduate, pioneer batch of Doctor of Dermal Sciences, Masters in Healthcare Management, PGD Health Emergency and Disaster Management, lecturer and program leader in Superior University, Lahore. Her title of talk is Exploring the Perceptions of Healthcare Professionals Towards Using Artificial Intelligence.
Thank you so much. Assalamu alaikum. Okay. So basically today I'll be presenting my research that I have done in my MS. I'll try to be bilingual ताकि हमारा एक interaction रहे और आप लोगों को ज़्यादा अच्छे से बात समझ आ सके. So what was the topic of my research? It was basically कि जी हम perceptions देखेंगे, हम thought processes देखेंगे healthcare professionals के specifically in पाकिस्तानी context कि जब वो artificial intelligence जो है वो इस्तेमाल करते हैं healthcare को deliver करने के लिए. अब आर्टिफिशियल इंटेलिजेंस से हमें बड़ा ना एक एलियन सा रोल जहन में आ जाता है. कोई रोबोट्स होंगे सर्जरी करते हुए और कोई बहुत बड़ी बड़ी मशीनें होंगी और सर्वर्स होंगे. इट्स बेसिकली नॉट लाइक दैट. जो ये गूगल है हमारे पास, इट इज़ आर्टिफिशियल इंटेलिजेंस. आपके पास ओरेकल है, आपके पास सारी इंटीग्रेटेड जितना भी हमारे पास हम हेल्थ इंफॉर्मेशन सिस्टम्स पर काम कर रहे हैं वो सारा लाइक यू टाइप द नेम ऑफ एन एंटीबायोटिक आधा भी लिखा होता है तो आपको सजेशन आ जाती है कि आप एरिथ्रोमाइसिन लिखना चाह रहे हैं या कौन सा एंटीबायोटिक है. सो ये सारा कुछ हमारे पास आर्टिफिशियल इंटेलिजेंस के अंदर आता है. अगर आपने लिटरेचर को देखें तो लिटरेचर बताता है कि 21st सेंचुरी के अंदर हमारे पास आईटी ने हर चीज़ ने बहुत ज़्यादा सक्सेसफुली जो है वो हेल्थ केयर सिस्टम्स को उनके लाइक पार्ट हमने उसका बना लिया, हमने काम करना शुरू कर दिया उसके ऊपर. और नो डाउट वी टॉक अबाउट डाटा प्रोसेसिंग, वी टॉक अबाउट डायग्नोसिस, वी टॉक अबाउट स्क्रीनिंग. तो हमें नो डाउट आर्टिफिशियल इंटेलिजेंस ने बहुत ज़्यादा असिस्ट भी किया है और हेल्प भी किया है. ठीक है. सो दिस इज़ व्हाट लिटरेचर टेल्स अस अबाउट. बट कमिंग टू माई रिसर्च, गैप क्या था? जब लिटरेचर को हमने आर्टिफिशियल इंटेलिजेंस के कॉन्टेक्स्ट में देखना शुरू किया स्पेसिफिकली फ्रॉम 2019 ऑनवर्ड्स, तो हमें ये बात समझ आई कि आर्टिफिशियल इंटेलिजेंस काम तो बहुत अच्छे कर रहा है बट कोई प्राइवेसी कंसर्न्स हैं, कोई कॉन्फिडेंशियलिटी है मरीज की जो ब्रीच हो जाती है, पेशेंट की कॉन्फिडेंशियलिटी. और ये हो क्यों रहा है? बिकॉज हमारे पास रेगुलेटरी बॉडीज नहीं हैं, हमारे पास पॉलिसी मेकर्स नहीं हैं. सो दिस वॉज द बेसिक गैप कि व्हाट आर द प्राइवेसी कंसर्न्स and are there any privacy concerns or not? And secondly, if there are some privacy concerns, who are the regulatory bodies, what are they doing, and what are the terms and conditions of use of that particular artificial intelligent technology? यहाँ पर हमारे पास जो है वो स्ट्रक्चरल मॉडल आ जाता है मेरी रिसर्च का. देखें, कोई भी टेक्नोलॉजी होती है तो हम उसको दो तरह से एवेल्युएट करते हैं. आप लोग आम एग्जाम्पल के लिए फेसबुक को ले लो. ठीक है. अब फेसबुक अगर है तो मैं उससे दो चीज तरह की तरह जब एवेल्युएट करूंगी कि एक तो वो मेरे लिए यूजफुल हो, ठीक है, और दूसरा वो इस्तेमाल करने में भी आसान हो. तो कोई भी टेक्नोलॉजी हम जब हेल्थ केयर में इनकॉर्पोरेट करते हैं तो हेल्थ केयर प्रोफेशनल भी यही देखता है कि एक तो वो टेक्नोलॉजी मेरे लिए काम की है, यूजफुल है, दैट इज एक्चुअली परसीव्ड यूजफुलनेस ऑफ दैट टेक्नोलॉजी, और उसके बाद क्या वो आसानी से इस्तेमाल भी हो सकती है. मुझे कोई बहुत हार्ड एंड फास्ट सॉफ्टवेयर या हार्डवेयर नॉलेज तो नहीं चाहिए उसको इस्तेमाल करने के लिए. एंड दैट इज बेसिकली परसीव्ड ईज ऑफ यूज. जब हमारे पास कोई भी टेक्नोलॉजी, कोई भी सॉफ्टवेयर इन दो चीजों के ऊपर पूरा उतर आता है दैट यस इट इज यूजफुल एंड इट इज इजी टू यूज, तो हमारे दिमाग में एक इंटेंशन बन जाती है उस टेक्नोलॉजी को इस्तेमाल करने की. जब इंटेंशन बन गई तो अल्टीमेटली विल गो टुवर्ड्स द एक्चुअल यूज ऑफ दैट टेक्नोलॉजी. चलें अब इसको एआई और हेल्थ केयर के कॉन्टेक्स्ट में ले आते हैं। हम हेल्थ केयर प्रोफेशनल्स हैं, हमारे पास डिफरेंट एआई टेक्नोलॉजीज हैं, सॉफ्टवेयर्स हैं, डायग्नोसिस के लिए, स्क्रीनिंग के लिए, डाटा इंटरप्रिटेशन के लिए। और आई नो कि बीइंग अ हेल्थ केयर प्रोफेशनल वो टेक्नोलॉजी ईजी टू यूज़ है और वो टेक्नोलॉजी मेरे लिए यूजफुल है। अब मेरे दिमाग में उस टेक्नोलॉजी को यूज करने की इंटेंशन बन चुकी है, बट देर आर टू मोर थिंग्स, द प्राइवेसी कंसर्न्स अटैच टू दैट टेक्नोलॉजी and the regulatory standards to attach to that technology. अगर privacy concerns like कोई भी privacy concern नहीं है, everything is okay, and after that if there are policies, मुझे प्रॉपरली एक मैनुअल दिया गया है, एक गाइड बुक दी गई है कि इस तरह से आप इसको काम में ला सकती हैं, तो ओनली देन बाय दीज टू फैक्टर्स कैन वी लीड टुवर्ड्स द एक्चुअल यूज ऑफ दैट टेक्नोलॉजी। ठीक है, सो यहाँ से हमारे पास जो है वो हमारे हाइपोथेसिस डेवलप हो जाते हैं कि नो डाउट इंटेंशन तो डेवलप हो गई टेक्नोलॉजी को इवैल्यूएट करके, बट आगे जाने के लिए दो चीजें बहुत लाजमी हैं कि प्राइवेसी कंसर्न्स क्या हैं और हमारे पास रेगुलेटरी स्टैंडर्ड्स क्या हैं, उसकी यानी कि टर्म्स एंड कंडीशंस ऑफ यूज क्या हैं। एक चीज यहाँ पे आई वुड लाइक टू क्लियर कि हमने यहाँ पर कोई एसोसिएशन नहीं लगाई थी। मोस्टली हम रिसर्चेस में एसोसिएट कर देते हैं positive impact, negative impact, strong relation, weak relation, but here we were totally open for the reason कि हमने healthcare professionals की perceptions को ही check करना था, हमने उन्हें एक वे में लीड नहीं करना था कि इसका पॉजिटिव इंपैक्ट ही आएगा। ठीक है, सो वी जस्ट आइडेंटिफाइड द रोल्स कि ये कुछ मॉडरेट कर रहा है, कोई रोल अपना प्ले कर रहा है। अब वी डोंट नो कि ये पॉजिटिव रोल है, नेगेटिव है, स्ट्रॉन्ग है या फिर वीक है। रिसर्च मेथोडोलॉजी की अगर मैं बात करूं तो इट वाज नॉट ओनली ऑन क्वांटिटेटिव मेथड बट इट वाज अ मिक्स मेथड स्टडी वेयर वी आल्सो took information in qualitative manner. I'll define this thing, इसको मैं मजीद आगे एक्सप्लेन करूंगी। इसके अलावा ये एक प्रिडिक्टिव रिसर्च अप्रोच है कि हम जो है वो परसेप्शंस को हेल्थ केयर प्रोफेशनल्स जब प्रिडिक्ट करेंगे तो उससे हम बताएंगे कि इसके रिजल्ट्स क्या निकलते हैं। हमने प्रीवियसली कोई रिलेशंस इसके अंदर डिफाइन नहीं किए। थर्डली हमारे पास जो रिस्पोंडेंट्स थे वो हेल्थ केयर प्रोफेशनल्स थे 3 सिटीज से, बेसिकली लाहौर जहाँ पे मैं आई वाज वर्किंग एंड इस्लामाबाद पिंडी जहाँ पर मेरा एमएस का कैंपस था। आफ्टर दैट अगर मैं दोनों पार्ट्स की क्वांटिटेटिव एंड क्वालिटेटिव पार्ट की डाटा कलेक्शन की बात करूं तो वो हमने गूगल फॉर्म्स के थ्रू कलेक्ट किया था। एंड लास्टली क्या है कि हमारे पास सैंपल साइज 100 था जो कि कन्वीनियंट सैम्पलिंग की गई थी। आई नो पीपल एंड दे नो पीपल, और हमने इस तरह से वो गूगल फॉर्म आपस में सर्कुलेट किया एंड वी गैदर्ड सम इंफॉर्मेशन। अब उसके बाद हमारे पास जब वो इन्फॉर्मेशन आ गई, क्वांटिटेटिव भी और क्वालिटेटिव भी, तो उसको एनालाइज करना था। क्वांटिटेटिव पार्ट को हमने स्मार्ट पीएलएस के थ्रू, एक हमारे पास जो है वो क्वांटिटेटिव तमाम डेटा को एनालाइज करने का टूल है, उसके थ्रू हमने एनालाइज किया। एंड क्वालिटेटिव पार्ट को हमने कंटेंट एनालिसिस के थ्रू एनालाइज किया। सो यहाँ पर इट इज़ जस्ट सम वैल्यूज जो कि हमें बता रही हैं कि जो भी हमारे पास डेटा क्वांटिटेटिव पार्ट में आया था वो तमाम क्वेश्चंस वही चीज़ मैयर कर रहे थे जो हम मैयर करना चाहते थे, विच मीन्स के all of the you can say the scales and all of the questions were well aligned with the parameters or with the variables that we were intended to measure. ये मैंने यहाँ पर कुछ क्वेश्चंस कोट किए हैं, जैसे अगर हमारे पास रेगुलेटेड अनरेगुलेटेड स्टैंडर्ड्स की बात करूँ तो द फर्स्ट क्वेश्चन वाज आई हैव कंसर्न्स दैट इन पाकिस्तान पॉलिसीज फॉर एआई टूल्स आर नॉट क्लियर, और फिर कोई ऑप्शंस थी, आप डिसएग्री करते हैं, आप स्ट्रांगली डिसएग्री करते हैं, न्यूट्रल हैं, अग्री या फिर स्ट्रांगली अग्री। ठीक है, तो ऐसे ही हमारे पास प्राइवेसी कंसर्न्स के भी क्वेश्चंस थे, और मेरे सारे वेरिएबल्स के 3 क्वेश्चन ईच हमने हेल्थ केयर प्रोफेशनल्स जो हमारे पास 100 का सैंपल था उससे हमने ये डाटा फिल करवाया। तो जब हमने ये डाटा फिल करके क्वांटिटेटिव पार्ट का आ गया तो इसके रिजल्ट्स में क्या आया कि बोथ ऑफ द हाइपोथेसिस वर प्रूवन ट्रू इन अ मैनर कि दे हैव स्ट्रॉन्ग पॉजिटिव इंपैक्ट। अब इसका मतलब क्या है? इसका मतलब बेसिकली ये है कि जब मैंने एक चीज को यूज करने की इंटेंशन बना ली, ठीक है, आई हैव द इंटेंशन टू यूज आर्टिफिशियल इंटेलिजेंस, no matter there are privacy concerns and no matter there are unregulated standards, even then I am going towards the actual usage of that technology. यहां तक तो बात ठीक थी, क्वांटिटेटिव डाटा आया, डाटा एनालाइज किया, जवाब आ गया हमारे पास, ठीक है। बट the thing that shocked us, that was the analysis of qualitative part. देखें, एक ही रिसर्च है तो क्वांटिटेटिव पार्ट को और क्वालिटेटिव पार्ट को के आंसर्स को अलाइन करना चाहिए ना आपस में, क्योंकि जो 100 बंदा क्वांटिटेटिव का आंसर दे रहा है वही 100 बंदा क्वालिटेटिव का आंसर दे रहा है, हमने सैंपल तो चेंज नहीं किया, ठीक है। बट जब हमारे पास क्वालिटेटिव पार्ट का कंटेंट एनालिसिस किया गया तो वी हैड दैट इंफॉर्मेशन कि जिन लोगों ने ऊपर ये बात की है कि इंटेंशन टू यूज के बाद प्राइवेसी कंसर्न्स और अनरेगुलेटेड स्टैंडर्ड्स के बावजूद वी गो टू एक्चुअल यूजेज, वही लोग नीचे ये कह रहे हैं कि हम एआई को हेल्थ केयर में इंप्लीमेंट नहीं करते क्योंकि कॉन्फिडेंशियलिटी के ब्रीचेस आते हैं। डिफरेंट हमारे पास जो एप्स हैं, डिफरेंट जो हमारे पास टेक्नोलॉजी है, वो डाटा सेल करती है डिफरेंट फार्मास्यूटिकल इंडस्ट्रीज को, डिफरेंट कॉस्मेस्यूटिकल इंडस्ट्रीज को, डिफरेंट और जो लोग मार्केटिंग करते हैं उन सबको ये डाटा सेल किया जाता है, ठीक है। सो देयर वाज अ क्लियर कॉन्ट्रडिक्शन बिटवीन द क्वांटिटेटिव पार्ट एंड द क्वालिटेटिव पार्ट। सी क्वालिटेटिव एनालिसिस की अगर मैं बात करूं तो हमने क्वेश्चंस कुछ ऐसे पूछे थे कि व्हाट इज योर ओपिनियन ऑन यूजिंग एआई इन हेल्थ केयर सेक्टर स्पेशली रिगार्डिंग द कॉन्फिडेंशियलिटी ऑफ पेशेंट्स हेल्थ इंफॉर्मेशन। तो इसमें हमारे पास जितने भी पार्टिसिपेंट्स थे जिनने ऊपर क्वांटिटेटिव में यस नो के अंदर बड़ा लिमिटेड आंसर दिया था, बट जब उनका ओपिनियन पूछा गया तो दे वर वेरी वोकल अबाउट दैट थिंग कि हम एआई को इंटीग्रेट नहीं कर सकते ड्यू टू दीज कंसर्न्स, कि हमें प्राइवेसी कंसर्न्स हैं, अनरेगुलेटरी स्टैंडर्ड्स आते हैं। तो इतनी हमारे पास जब ये आ गई, इसके अंदर यू कैन से कि इतनी कॉन्ट्रडिक्शन आ गई, तो इसका कंक्लूजन क्या बनता है? Even while presenting my thesis in my defense, everybody was like कि ऐसे thesis approve नहीं होते, आपका defense clear नहीं होगा. But this was what my research finding was, and this was the thing that I wanted to put in front of my instructors. And that totally is in a way कि एक तो आंसर्स को यहाँ पर रहने देना कि क्वांटिटेटिव पार्ट ने ये बता दिया कि प्राइवेसी कंसर्न्स हैं और अनरेगुलेटेड स्टैंडर्ड्स के बावजूद हम एआई यूज कर रहे हैं, एंड क्वालिटेटिव पार्ट को भी आप जस्ट लीव इट कि उसके आंसर्स क्या थे। वी हैव टू इवेल्युएट दिस रिसर्च बियॉन्ड दीज क्वांटिटेटिव एंड क्वालिटेटिव आंसर्स. वी हैव टू इवेल्युएट दिस रिसर्च इन कॉन्टेक्स्ट ऑफ द अप्रोच ऑफ रिसर्च. जब आप पॉलिसी मेकर होते हुए, जब आप किसी भी इंस्टीट्यूट में एजुकेशन को लीड करते हुए ये मैंडेट बनाते हैं या ये बात आप करते हैं कि नेक्स्ट 5 साल में हमारी यूनिवर्सिटी वन ऑफ द लीडिंग रिसर्च यूनिवर्सिटीज ऑफ पाकिस्तान होगी, या जब आप ये एक चेक लगा देते हैं कि तब तक आपको HEC MS की डिग्री नहीं देगा जब तक आप HEC रिकग्नाइज्ड जर्नल के अंदर अपना जो है वो थीसिस पब्लिश ना करा दें, बट उसके तमाम प्री रेक्विजिट्स के अंदर क्या आपकी रिसर्च अप्रोच और क्या आपका रिसर्च कराने का तरीका इस स्टैंडर्ड के ऊपर है कि आप उन तमाम चीज़ों को, या आप मेडिकल एजुकेशन में इवन ये मैंडेट भी दे सके कि हम इस तरह की कोई भी चीज़ डेवलप करना चाह रहे हैं या हम लीडिंग यूनिवर्सिटी होंगे इन टर्म्स ऑफ रिसर्च एंड ऑल दैट. सो कहने का मकसद सिर्फ ये है कि रिसर्च अप्रोचेस फ्रॉम स्ट्रांगली अग्री, स्ट्रांगली डिसअग्री, यस नो, हमें इससे बढ़ के रिसर्च अप्रोचेस की तरफ जाना है. व्हेन वी टॉक अबाउट रियल ह्यूमन लाइव्स, व्हेन वी टॉक अबाउट हेल्थ of people, when we talk about allied health professionals, and when we talk about healthcare management in Pakistan. ठीक है, सो वी हैव टू राइज अबव दीज ऑल थिंग्स. और स्पेसिफिकली जब आपने कोई टेक्नोलॉजी इंट्रोड्यूस करानी है, जब कोई इंटरवेंशन इंट्रोड्यूस करानी है, तो द पीपल हु आर यूजिंग दैट टेक्नोलॉजी, उन लोगों के लिए प्लीज मेक दोज पीपल फील ओपिनिएटेड. अगर कोई डॉक्टर, कोई फिजिशियन, कोई अलाइड हेल्थ प्रोफेशनल उस टेक्नोलॉजी को यूज कर रहा है, तो उस टेक्नोलॉजी के फायदे और नुकसान एक यस नो के आंसर के ऊपर उनको एवेल्युएट ना करें. Make the people who are using that technology, plus जिन पर वो टेक्नोलॉजी यूज हो रही है, द पेशेंट्स, मेक दोज पीपल फील ओपिनिएटेड. एंड रिसर्च अप्रोचेस के अंदर क्वालिटेटिव रिसर्च अप्रोच को, ओपिनियन बेस्ड रिसर्च अप्रोच को जो है वो हमें ज़्यादा यू कैन से के फोकियत देनी चाहिए, या फिर एटलीस्ट हमें अपने बच्चों को जो है वो इस बात पे एनकरेज करना चाहिए कि येस यू कैन गो फॉर क्वालिटेटिव रिसर्च टू. इट इज़ डिफिकल्ट बट इट इज़ मोर रिक्वायर्ड. अगर मैं नीड ऑफ द आवर की बात करूँ, एज ऑलवेज हमारी हर चीज़ की कोई ना कोई लिमिटेशंस होती हैं. इस रिसर्च की भी लिमिटेशंस थी कि सैम्पल साइज बहुत थोड़ा था, क्योंकि इट वाज जस्ट 4 months, तो 100 का हमारे पास सैम्पल साइज था. इसके अलावा लाहौर, इस्लामाबाद, पिंडी के अलावा हमने कहीं और से सैम्पल्स नहीं लिए. देन अगेन ये चीज़ कि हमने डिफरेंट हेल्थ केयर प्रोफेशनल्स को, जो कोई डर्मेटोलॉजिस्ट भी हो सकता है, रेडियोलॉजिस्ट भी हो सकता है, उन सारों को हमने अंडर वन अम्ब्रेला रखते हुए इसको चेक किया. एंड थर्डली ये कि हमने कोई भी सेग्रीगेशन नहीं की कि कौन कौन सी आर्टिफिशियल इंटेलिजेंट टेक्नोलॉजी हम यूज कर रहे हैं, ठीक है। सो फ्यूचर इम्प्लीकेशंस, यहाँ पर जितने भी यंग रिसर्चर्स बैठे हुए हैं, इसी सेम मॉडल को, इसी सेम रिसर्च को आप कंटिन्यू कर सकते हैं। और उसमें ये चीज़ कि एक तो सैम्पल साइज को लार्ज रखें, दूसरी बात ये कि एटलीस्ट पाकिस्तान की डेमोग्राफी को ज़्यादा कवर करें। थर्डली ये कि प्रोफेशनल बैकग्राउंड्स को अलग कर दें कि एक रेडियोलॉजिस्ट क्या सोचता है, एक सर्जन क्या सोचता है, उसकी क्या परसेप्शंस हैं। एंड लास्टली ये चीज़ हमारे पास कि आप जो है वो टेक्नोलॉजीज को भी डिस्क्रिमिनेट कर दें कि स्क्रीनिंग टेक्नोलॉजीज के क्या प्राइवेसी कंसर्न्स हैं, या फिर हमारे पास डाटा एनालिसिस के टेक्नोलॉजीज के क्या प्राइवेसी कंसर्न्स हैं। सो दैट वाज ऑल फ्रॉम माय साइड। एनी क्वेश्चंस? थैंक यू सो मच।
Thank you, Ms. Atia Anwar, for the fascinating presentation on artificial intelligence. Your research is a reminder that the future of healthcare is intertwined with technology, and we must all be prepared to embrace these changes to improve patient care. Thank you all for your incredible contributions. Each presentation has truly enriched our understanding of health sciences, and I hope you all have taken away new insights. I would now like to invite Professor Dr. Musarat Hasnan, the chair of this session, to give his concluding remarks.
Bismillah ar-Rahman ar-Rahim. This scientific session has been very, very relevant, and it included all the essential topics which were kind of essence of this conference, which we call it as Skin Connects. Professor Gohar Wajid was very specific about the role of allied health professionals in attaining the universal coverage, which is goal of the one of the goals of sustainable development goals of the WHO. He emphasized on the matching of number of health professionals, including doctors, nurses, allied health professionals, to fill the gap which is there and which he called as critical gap between healthcare givers and the population of developing countries, especially Pakistan. And then he also talked about absorption of these graduates which are coming out of the universities. And I think this is very, very pertinent point, which all the education institutions should consider. As we all know that the number of doctors we require is certainly more than what being produced in Pakistan. And same is the case with nurses, allied health professionals. But there is mismanagement as regards the employment of these people. And this gives rise to dissatisfaction and depression in the youth, which is very, very detrimental for Pakistan or for any country for that purpose. And then he talked about family practice, and that should be the health system should be reoriented, and main focus should be family practice. In that way, it would be integrated. Lastly, he talked about the technologies which are coming up, and we should try to adopt those technologies. Dr. Noor gave us insights about artificial intelligence. Artificial intelligence, which has revolutionized all the sectors and all the educational platforms, as well as development of different countries. This revolution is a big one, and it's not easy to engulf or swallow. So we need to be prepared at a greater pace to adopt these new technologies, because this can be double-edged weapon, like mobile and all other technologies we come across. She was more talking about artificial intelligence, and I would like to add to it, that is artificial general intelligence, which is the next wave coming in. And I think we should get prepared for that as well, because that will take us ahead of artificial intelligence, because artificial intelligence is based on large linguistic models, and that's a different technology than artificial general intelligence, which is even much more advanced than artificial intelligence. And I think we should get prepared for that. Dr. Komalata, I would say her interactive lecture was more like a workshop. And she kind of let us experience those. Rather, it was a hands-on lecture, I would say, than the simple lecture standing at the podium. So most of the talk was about communication and its importance in our everyday practice as we move from single to the team-based working. Now this individuals are not assessed. The performance or outcome is assessed that of a team rather than individuals. So communication has become even more important. But I can imagine that all the participants, they rather went through the hands-on experience of communication regarding our clinical setup. Then was Dr. Atia. She went ahead with the AI and shared her own study regarding AI. This was about the deep insight into the perceptions and how we take this internally. And there was something very, very important, and I would say a new thing for me, that the qualitative results did not match quantitative results. When I came this morning, there was something going on here, and it was a survey form being shared here. It was regarding colorism, and I was talking to my next seat person and telling that I think the survey won't be realistic, because even deep in our minds, when we are answering these questions, we have a definite hesitation and reluctance, even if it is anonymous. So that is part of our unconscious mind, and that is not an honest answer when we are giving the answer to yes or no. And that practically happened probably with the Dr. Atia's study. So when we see some individuals and we want to determine whether they are malingering or they have actually some problem, we get them admitted in the hospitals and watch them for over a long period. So the survey form is there for 10 minutes with us. and we can, pose, or we can show certain things which are not there in our own mind, but that is just posing. But talking about qualitative study is different, and it gets to the deep feelings. So I think that was one of the reasons why she got a different result from quantitative and qualitative. And we should keep these reasons in mind when we are doing studies on these sensitive topics, as she did. Uh, by and large, it was a very informative session. All the speakers, I won't comment on my own talk, because all the audience have their own views and they can comment in it. All the speakers, they were very, very relevant, and they gave us information which we carry home. It will benefit us in our practice. And thank you very much again for honoring me to preside this session.
As we reach the conclusion of second scientific session of ICDS 2024, I request the chair of this session, Professor Dr. Musaratul Hasnan, to present certificates and souvenirs to the presenters for their valuable contributions and presence. I would like to invite Dr. Komalita to please come on stage and receive the certificate. आगे बच्ची को जल्दी जाके लेके जाओ। मैं मतिया Thank you, ma'am. Now I would like to invite Miss Satya Anwar to come on stage. Dr. Ian. Sir, Professor Dr. Hamid. I respectfully request Professor Dr. Tanzila Khalid to present souvenir to the chair of this session. Dermal. Thank you so much.
Thank you.
This session to a close, I would extend my heartfelt gratitude to our esteemed speakers for their thoughtful contributions. Thank you.
Audience, please maintain silence. Assalamu alaikum and good afternoon, everyone. I am Ariba Bint Akhtar, Student Conference Coordinator, and I will be moderating this session, which is one of the most crucial parts of our conference, the Young Researchers session. This session is dedicated to showcasing the work of devoted students and young researchers who are passionate about advancing the field of dermatology. We are thrilled to provide a platform for their innovative ideas and fresh perspectives. Our session today is chaired by Ms. Atiya Anwar, a distinguished graduate Doctor of Dermal Sciences from the University of Faisalabad. She is a gold medalist and has completed her master's in healthcare management. Ms. Atiya has also contributed significantly to academia through her teaching engagements at various universities. Supporting her as the session co-chair is Ms. Kinza Arif, also a graduate Doctor of Dermal Sciences from the University of Faisalabad. She is a silver medalist and currently serves as a physician associate. In addition, Ms. Kinza is pursuing a master's in tissue viability and wound management from the University of Huddersfield, UK. I would request Ms. Atiya and Ms. Kinza to please take the seats on stage. So without further ado, let's move to our first presenter. Our first presenter is also Ms. Kinza Arif. She will be presenting on reviving neglected wound, a case report of an untreated dog bite injury in Pakistan. Please welcome Ms. Kinza Arif.
Okay. Assalamu alaikum and good afternoon, everyone. This is me, Kinza Arif. I'm a graduate of Doctor of Dermal Sciences batch 2022 and currently doing my master's in tissue viability and wound management from the University of Huddersfield. So, today my topic of presentation is basically a case report titled as Managing Neglected Wound, a case report of an untreated dog bite injury in Pakistan. So you will know the title later after knowing the presentation of the talk. So basically, dog bites are a significant public health concern in Pakistan, particularly due to presence of stray dogs in both rural as well as in urban areas. And why this is a significant public health concern? Because animal bite induce rabies virus into the human body, and this rabies virus directly affect the central nervous system, causing irreversible neurological damages. So that is why dog bites are a significant public health concern in Pakistan. The second major concern is that after the dog bite, there is a need of rabies virus. So rabies post-exposure prophylactic measures is basically an immediate measure that is usually required after an animal bite. And most commonly in the dog bite we have seen in Pakistan. So basically over 10 million people receive rabies post-exposure prophylaxis and Pakistan is ranking 5th globally. So that is why this is the main topic of the concern we need to discuss. Okay. According to World Health Organization class of dog bites or rabies exposure, there are basically three categories of animal bite. If an animal simply lick or feed the human body, then this will be labeled as category 1 dog bite or an animal bite. If an animal cause abrasion or simply erosions over the human body through touching or through scratching, then it will be labeled as category 2 animal bite or a dog bite. And if the animal induced their nails or a teeth into the human body, then it will be labeled as category 3 animal bite. So in all of these three categories, in category 1 animal bite, where the animal simply lick or touch the human body, there is no exposure of the skin, there is no blood loss, then there is no need of rabies virus in that scenario. If the animal scratch the human skin, cause abrasions or erosions over the human body, there will be or will not be the blood loss at that respective area. It will be labeled as category 2, and yes, there is a need of rabies vaccine against anti-rabies vaccine for that particular person. And if the animal introduce their teeth or their nails into the human body, and there will be a large amount of blood loss at that respective wound, then yes, there is a need of anti-rabies vaccine to protect the body from that rabies virus. So basically, we have seen and we have discussed that yes, there is a need of anti-rabies vaccine for the rabies virus that is being introduced by the animal bite or a dog bite. But we all neglect the major concern that is very neglecting for the patient or for the patient health, that are the bacteria being introduced by the saliva of an animal to that respective area. So rabies virus introduced into the human body and affect the central nervous system. An anti-rabies vaccine immediately given after the animal bite protect the body from that rabies virus. But the bacteria introduced through a saliva of an animal cause local or systemic wound infections, and that is the major neglected area in Pakistan, or because the wound care is overall all neglected area in Pakistan. So basically, in my case presentation, there was a 53 years old woman lady presented to dermatology and plastic surgery unit with 14th day of the post-bite infection at her left lower leg. Immediately after the dog bite, she went to the nearby hospital. The nurses washed the wound and did local dressing and refer her to tertiary care hospital. At tertiary care hospital, she was given anti-rabies vaccine, and basically there are 3 doses of anti-rabies vaccine at day 0, at day 3, and at day 7. And after the 3 doses, she was advised to wash the wound and apply iodine over the wound. So till 14 days, she has been administered 3 doses of anti-rabies vaccine, but no wound care was taken. So after 14 days, she presented to dermatology and plastic surgery unit with 2 wounds present on her left lower leg. So basically, this was the initial presentation of the wound. अगर ये lights are off हो जाए, pictures clear हो जाएंगे. So basically, there were 2 wounds present on her left lower leg. The first one is present at the posterior side, and the second one is present at the lateral side, because the dog typically insert their jaws into the leg, and there were 2 deep lacerations on her left lower leg. And both of them are covered with dead necrotic tissue, because till 14 days, no wound care was taken. So, what comes into your mind? What will be the management to revive this neglected wound? As we all know that skin is a regenerative organ, and if we do not care the skin, we do not provide proper wound management, then skin cells start getting die, and this dead skin cells provide anaerobic environment to anaerobic bacteria to grow and cause wound infections. So basically, the immediate wound care is to wash the wound and remove those necrotic area to remove the anaerobic environment for the bacteria. So basically, in any wound care, the main major point is to moisturize the wound, repeatedly cleansing and moisturizing the wound. Skin is a regenerative organ, and skin cells only regenerate after getting moisture content from the external environment. All skin cells, epidermis, dermis, lower down muscles, tendons, ligaments, bones, either they are poorly vascularized or highly vascularized structures, they need proper moisture content to grow and to regenerate. And in this scenario, as it is a wound, and we will provide local moisture in the form of topical antibiotics, in the form of cream or emollient that is actually a topical antibiotic. So basically, the immediate wound management that was given to this respective patient is to regular cleansing and washing the wound and apply topical antibiotics. And we have to cover the broad spectrum area. So we have given those antibiotics that is respective against for both gram-positive and gram-negative bacteria. Secondly, it's a deep wound, laceration, a large amount of blood loss, so we have to given the oral antibiotics as well. Third one is for the management of the wound or proper management of the wound, we need to remove the inflammation from that respective area, and this inflammation will help the wound to heal or the skin cells to regenerate. So basically, 4 steps will be taken in this scenario. Number one, oral antibiotics according to the patient current health condition for respective days. Number two, topical antibiotics that are very provide broad coverage against both gram-positive and gram-negative bacteria. Number third is anti-inflammatory to reduce the inflammation at that respective area. And number four, counsel the patient and advise the patient for regular cleansing and washing the wound, and then apply topical antibiotics. So I am going to show the result right after 1 day. So basically, this picture is from the 14th day of the post-bite wound. Until 14 days, the patient did not take care of the wound. And after 1 day of the wound care, the patient was presented with this picture. So you can see that we can see the pink granulating wound base. Granulation tissue, there are 2 types of healthy tissues that helps in the wound healing. Number one, granulation tissue that comes from the wound base, and number two, epithelial tissue that comes from the wound edges. Granulation tissue fills up the wound base, and epithelial tissue close the wound edges. And in dog bite wound, we do not stitch the wound because wound is fully covered with bacteria. And when we stitch the wound dehiscence occur and wound immediately gets break up and open. So in this scenario, we will provide the secondary healing. Wound will heal and close by itself to protect the wound from local wound infection. So right after 1 day of the wound care, we have seen there is healthy granulation tissue present in the base, and epithelial tissue is present at the edges. So after day 4, the patient was presented at the day 4, which is actually a 17th day post-bite. So in day 4, wound has significantly reduced in the size, and we can see healthy pink granulation tissue is present at the wound base, and epithelial tissue is present at the wound edges. And simply she has taken the basic wound measures. Antibiotics will automatically stop after 6 to 7 days. Anti-inflammatory will automatically be stopped after 3 to 4 days. And pain care, she will continue the painkillers. And the main thing that will help in the wound healing is topical antibiotics to provide moisture as well as antibiotic coverage. So after 10 days of the wound care, the patient was presented with this picture. Now you will be surprised that this pink tissue is literally covered with a yellow E-scar. So basically, whenever there is a wound healing, and when we apply the topical antibiotics, the exudate coming from the wound and topical antibiotics we are applying stick to the wound. So that is why the key point of the wound care respective to the moisturization is to immediately cleansing and washing the wound. And whenever we apply topical antibiotics, we have to cleanse or remove the previously applied antibiotic and then apply the newly fresh ointment and cream. So at this point, the patient was advised to regular cleansing and washing to remove those yellow slough and then apply the fresh antibiotic coverage. After 16 days of the wound care, the patient was presented with this yellowish is also a slough or a pseudo scar. You can say it is actually a debris or a waste material coming from the wound. And at this point, you can see the wound size has significantly reduced in size, and wound is actually closing in size. At day 23, wound is markedly closed, and healthy granulation tissue covers the bone base. Epithelial tissue is trying to close the wound edges, and we are sure that this wound will close in the next few days. And after this, the patient was presented after 1 month of doing this topical wound care. So after 1 month, the wound was significantly closed. We can not see any wound infection at that respective area. So the another key point you should take is whenever the normal healing process of a wound is 21 days. And when the wound heals after 21 days, there is always a risk of hypertrophic scarring. So at this point, because this was a neglected wound, a delayed presentation, then we should keep in mind that there is always a risk of hypertrophic scarring because wound takes a lot of time. At this point, what is the management of hypertrophic scarring? Simply unilateral massaging to remove the contractures or extra skin cells forming over the skin. So at this point, the patient was advised to do unilateral massages and unilateral ointment dressings to remove those contractures. So patient was advised to again take the follow-up. So at day 75, we can see there is a little bit of the skin lift, and that show there is the hypertrophic scarring is formed, and we should counsel the patient to follow up the plastic surgery department for this hypertrophic scarring. So what is a discussion we can discuss that anti-rabies vaccine is for the rabies virus, but wound is a wound, and wound always in need of the wound care, and this wound care should be in the form of regular cleansing and washing the wound and moisturize the wound. So the take home message for us is that we should understand the proper wound care, and in case of dog bite we should keep in mind the bacteria introduced through saliva of an animal. And yes, early and consistent wound care, even if we do it late, can result in successful healing and prevent further complications. So thank you so much. That was my part. If you have any question, you can ask me.
Thank you so much, Ms. Kinza, for such an informative presentation. Now I'll take the opportunity to present my own study. This was actually a group study, so I am presenting on behalf of my group. I am presenting on analyzing the relationship between patient preferences and physical appearance of skincare professionals, a cross-sectional study. Physical appearance plays a crucial role in how patients perceive healthcare providers, especially during initial encounters. According to our knowledge, there are numerous studies that highlight the impact of appearance on judgments of professionalism and trust. Even we found many studies on specific factors like gender and attire, but we found no study on how skin condition or skin health of a skincare provider could affect patient preferences. We did find one study on how physical attractiveness influences patient preferences. It was influence of physical attractiveness and gender on patient preferences in digital doctor consultations, an experimental study, and it was published in May 2024. So the objectives of our study were to determine the effect of physical appearance of skincare professionals on patient preferences, to identify key physical attributes such as gender, attire, skin condition that impact patient decisions. It was a cross-sectional study. It was conducted in Faisalabad in September 2024, and we used a structured questionnaire comprising 16 questions. It was distributed to 104 participants, mostly were female. Data were analyzed through descriptive statistics and chi-square test using SPSS. These were the research questions. Now I will quickly walk you through the main findings of our study. Education levels of participants showed that 72.1% were undergrad, 12.5% were below matriculation, and 8.7% had postgrad degrees. Financial situations varied, with 20% of participants financially weak, while 32.4% felt financially secure. On importance of attire, 76.2% felt it mattered for skincare professionals, indicating it plays a key role in patient perception. For preferred attire, 48.6% favored scrubs, while 37.1% preferred lab coats. Reasons for attire preferences were primarily for a performance look, a professional look, and cleanliness. In terms of attire's influence on revisit decisions, 57.1% said yes, while 28.6% said no. Regarding the importance of gender, 46.7% felt it mattered, while 51.4% said it didn't, suggesting gender can influence but isn't a primary factor. On preferred gender for discussing personal concerns, 49.5% chose female professionals and 44.8% chose male. When asked why, 76% cited comfort level as the main reason. Skin condition mattered to 95.2% of the participants, underlining its importance in shaping perceptions. Additionally, 83.8% believe skincare professionals should act as role models for healthy skin practices. For skin attributes, 47.6% prioritized healthy skin, while 29.5% focused on clear skin. Ideal skin health was defined as healthy glowing skin by 36.2% and clear well-maintained skin by 35.2%. Physical appearance influenced revisit decisions significantly, with 59.6% saying it impacted them a great deal. Finally, when asked which factor matters most, attire, gender, or skin health, 56.2% chose skin health as the most important, while 40% valued all three factors. To conclude, this study highlights that skin health is most influential factor in patient preferences, followed by attire and gender. These findings suggest a holistic approach is essential for skincare professionals, where both professional appearance and skin health practices are prioritized to foster patient satisfaction and trust. Thank you. Next, I'm pleased to welcome Ms. Momina Izhar, who will be presenting her study on the psychological impact and financial burden on melasma patients in Punjab, Pakistan. Let's give her a warm welcome to the stage.
Assalamu alaikum, everyone. My name is Momna Izhar, and I am here to present in front of you on behalf of my group. The title of our presentation is A Cross-Sectional Study of Psychosocial Impact and Financial Burdens in Melasma Patients of Punjab, Pakistan. So let's start with an introduction to melasma. Melasma is a common skin condition that manifests as dark pigmented patches due to the sun exposure, particularly on the face. It is a chronic skin condition and it is recurrent, so it negatively affects the quality of life. The prevalence is particularly high in individuals of Asian, Latin American, and Hispanic origin, and it commonly affects the Fitzpatrick skin type 3 and 4. So now moving towards the objective of our study, the aim of this study was to investigate psychosocial impact of melasma in Punjab and financial burden due to various treatment modalities in Punjab. Many studies have done on the psychosocial impact, but however, they often overlook the financial burden associated with the long-term treatment of melasma. So this creates a gap in understanding how financial strain enhances the psychosocial challenges faced by the patients. To fill this gap, we conducted this research in which we conducted a cross-sectional observational study across Punjab. We selected 27 patients and provided them with 2 questionnaires. One, to evaluate the psychosocial impact, we use RealQI, which has 10 questions, and to assess the financial burden, we use a financial burden composite score that have 8 options, and to ask the patients to choose any option that they have done for the treatment of their melasma. It was a convenient sampling technique. So, the results of the questions we were asked, how much does your skin condition make you feel frustrated? So about 25.9% patients choose the option 4, 3, and 4, being moderately bothered. About when we talk about unattractiveness, they choose option 33.3% patients choose the option 4, being moderately bothered. And when And when talk about the productivity, about 29.6% patients choose the option 1, being not bothered at all. While assessing the financial burden, about 20% patients chose you had to use their savings, and about 18% patient had to delay or interrupt treatment. So when we talk about the worry, how much do you worry about financial problems that have resulted from melasma and its treatment? So about 37% patients chose the option 3, being moderately worried about their skin condition. To conclude the result, our research shows that there is a considerable psychosocial impact, psychosocial distress, and significant financial burden among the patients. And this study findings can be used in healthcare policies to ensure that a patient with melasma gets proper care, addressing through his or her psychological and economic needs, and to counsel the patients properly. Thank you.
Audience, please maintain silence. Thank you, Momna. Following that, please join me in welcoming Ms. Zara Batul presenting on psychodermatological literacy in Faisalabad, a critical analysis of community understanding. Welcome, Ms. Batul.
Bismillahirrahmanirrahim. Assalamualaikum everyone. Today we will explore the slide on country.
There were some technical issues. Now we have Ms. Hafsa to present her research evaluating the influences, a descriptive study on students' motivation for selecting a dermal technology degree. Please welcome Ms. Hafsa.
Assalamu alaikum everyone. I am Hafsa from the Department of Dermal Technology. I'm going to present a group research. The topic, Raike? The topic of our research was evaluating the influence, a descriptive study on student motivation for dermal technology degree selection. Objectives. As we know that dermal technology is a growing field. So the main objective of our research was to determine which motivational factors influence students to choose dermal technology, and improving these motivational factors will help us to know how can we improve the academic performance and academic success of students. It will also help us to improve the future success and progress of our department. Methodology. A cross-sectional survey-based study was conducted in the University of Faisalabad from September to October 2024, where 41 female students answered our online survey-based questionnaire, and the students were enrolled in the Department of Dermatology. Results. Here are the results of our questionnaire. The question number one was, how did you first learn about dermal technology as a field of study? 51% students said they came to know about this degree from their family and friends, where 41% said from social media. The next question was, does social media influence students to choose derma technology as a degree? Where 44% said, yes, social media influence students to choose a degree. The next question was, how personal interest is important in selecting derma technology as a degree, where 82% said, yes, personal interest plays an important role in selecting a degree. The next question was, what primarily motivates you to choose derma technology as a degree? Where 75% said personal interest was their main priority for choosing this degree. And 15% said peer pressure or family pressure was their main concern. The next question was how much the recommendations or encouragement from family and friends influence your decision. 63% said that encouragement from the family influenced them very much for choosing derma technology. The next question was, did financial gain or the career prospect influence your decision? So 37% will strongly agree that financial gain plays an important role for selecting a degree. The next question was, did you enjoy learning about scientific innovation and advancement in derma technology? 76% of the students said they enjoy learning about new innovations and scientific advancement in the field of dermatology. The next question was, did the flexibility in career option like clinical, hospitals, or formulation have on your choice? Where 63% said that career flexibility influenced them to choose derma technology. The next and the last question was, which aspects of derma technology appeals or motivates you the most? Where 61% said aesthetic procedures appeal them the most, and 37% said clinical site appeals them the most, and 3% said scientific research and education, where 2% said formulations. In conclusion, a statistical analysis using chi-square was done to know which motivation factors influence. The result shows that both intrinsic and extrinsic motivation factors influence the decision of student to select derma technology as their degree. Understanding these motivational factors will help the institution to define their recruitment strategies, ensuring they align with student aspiration and market need. Thank you.
Thank you, Hafsa. Next, I invite Maida Razak to share her work on the prevalence of occupational dermatitis among individuals working in textile dyeing industries. A warm welcome to Ms. Maida.
So, Assalamu alaikum everyone. This side Maida Razak, and I am presenting in behalf of Group 9. So the title of our research is the prevalence of occupational dermatitis among workers of textile dyeing units. So in our introduction, let me first tell you that why we have chosen the subject of occupational dermatitis, especially relevant to the textile dyeing units, because as we have seen according to our research that there is no as such awareness and proper guidance on this specific topic from the past 10 years research articles. So this is our basically the objective where we have been assess the prevalence of the occupational dermatitis we have been visited so far. So there is no as such prevalence or assessment of the occupational dermatitis, but we have seen that the workers are continuously to the exposure of the dyes and chemicals in the industries. So there is a major factor that we want to highlight over here. There is a environmental correlation of the occupational dermatitis conditions, but we have more relatively observed the skin manifestations among them. So this is the methodology section in which we have use our main findings of the research. Like we have supposed to take the people which were have complication of skin dryness were of 80%, and the second were of blistering were the second most common issue among the textile workers, and third most was the redness, which was of 40%, and 20% of eczema skin indications on their hands and feet. And last, 5% of workers have the issue of skin peeling after the continuous exposure. So this is basically, as we have seen, that there is a dermatological prevalence, which were the main findings of our methodology, and the erythema is incidence, eczema presentation, observation duration was also being noticed. As you can see, the two pictures which we have been taken from the industries, the problems which were the most common over there were the complication of warts on their, especially on the back of their hands, as we can see in the second most picture. And this was basically happened due to the friction and the handling of the materials. And the second most was the pomphylex, and pomphylex were because of the painful blisters that we have seen on the back of their hand, and the white patches were seen also. So in our results, we have targeted so far the 5 textile mills. So the first was Dow Textile Mill, and the second was SN Dyeing Small State Industry, and third was Hina Sana Dyeing Textile Industry. Fourth was Nizami Dyeing Textile Industry, and the last was Ali Reza Khan Dyeing Textile Industry. So in our research approach, we have been conducted a physical based study and the clinical assessment by taking proper trials through medical camps and the survey questionnaire over there. So these are the prevalence that we have taken from there of this disease, that notably higher incidence of such workers were across among the 5 years of experiences working in the textile industry. Conclusion. So in the last slide, we have been conclude our study by applying the chi-square independence test because of the examined symptom related to this disease. So identifying the skin blistering and the dryness, which were the most common issues over there, and we have been taking the findings to reinforcement the necessity of taking the proper protective protocols in the textile industries to overcome such conditions. Thank you so much.
Thank you, Maida. Now let's welcome Ms. Sajda Askar, who will present her comparative study, Acne Treatment Preferences Among Men in Urban and Rural Areas of Faisalabad. Please join me in welcoming Sajda.
Wow. Assalamu alaikum. My name is Sajda and I'm the student of Dermal Science 7th semester. The topic of my research is acne treatment preferences. It's a comparative study of men in urban and rural regions of Faisalabad. So basically, acne, as we know that acne is the most prevalent skin issue, and it does not only affect your physical appearance, but it takes your confidence away. So we take different medications or try different remedies to treat it. As we know that acne does not have any gender. It affects both males and females. But in some cases, it has seen that the severity of acne is more in men because they have higher level of the androgen as compared to the women, which lead to the more sebum production, and that causes the acne breakout. So it's not working. Okay. So the objective of our research is that first we need to acknowledge that what men actually need to prefer for their treatment for acne. But then we need to acknowledge that what are the reasons that influence their preferences. The reason that could be affordability, accessibility, or their satisfaction level. The methodology of our research is that we did a cross-sectional study and we targeted 50 men from age 15 to 30 years, and we collected that data through the electronic surveys. And these are the results that 45.8% of the people that have been dealing with acne since a year and 8.3% since adolescence. And then 25% of the people, they prefer dermatologists for the consultation, while 16.7% they opt for the personal preferences via social media or friends or family. And 35% of the people, they feel like they do not consult a dermatologist because they feel like it's too time consuming. But the 20%, they do not have accessibility to the healthcare settings. And 34%, yeah, it's the same, the time-consuming treatment, okay. The natural remedies, okay. The final result that these were the overall results from the urban and rural regions. But the final results were that 70% of the men from urban regions, they prefer allopathic medications, and 50 to 60% of the men from rural regions, they prefer herbal remedies. The conclusion of our study is that our research help us to develop those healthcare policies that helps to better serve for everyone and that reduce these disparities that we are talking right now. Thank you.
Thank you, Sajda. Next, I invite Ms. Sahar Fatma to share her work on assessing knowledge and perceptions regarding lifestyle and environmental factors influencing premature graying of hair among adults in Faisalabad. Welcome, Sahar.
Good afternoon, everyone. So the title for my research is Assessing the Knowledge and Perception of Lifestyle and Environmental Factors Influencing Premature Graying of Hair in Young Adults in Faisalabad. Imagine getting up every single day and being less confident about something because of a reason that is out of your control. This is the reality of many young adults faced with premature graying of hair. Premature graying of hair does not only impact the physical appearance of a person, it also impacts the self-esteem, the confidence level, body image, and overall mental health of the persons. Premature graying of hair, despite it being despite it having high prevalence, basically multiple
lifestyle and environmental factors contribute to this, yet the awareness of this is still very limited among individuals. The main objective of this study was basically to understand the perceptions of individuals faced with this problem. We wanted to know about the thoughts and beliefs of these people regarding these factors. And the primary reason for that was so in the future, when we implement healthcare initiatives and educational workshops, we can provide better education and cater to their needs effectively. Let's look at the background, a little bit of it. So previous studies suggest that aside for genetic factors, multiple non-genetic factors such as diet, stress, and environmental pollution also contributes to premature graying of hair. Yet many individuals are unaware of this and the impact of these factors on premature graying of hair. Similarly, dietary deficiencies such as vitamin B12 and copper also contributes to premature graying of hair. At the same time, chronic stress basically depletes the melanocytes, which accelerates the graying of hair. And pollution and environmental harmful elements also damages the melanocytes, which leads to premature graying of hair. There are multiple studies that have talked about the impact of non-genetic factors on premature graying of hair, but there are very few studies that talk about people's perception and knowledge regarding the influence of these factors. So this study was done to fill in that gap so we can understand young people's perception of lifestyle and environmental factors. The methodology used for this was cross-sectional survey, which was collected through non-probability sampling. The study targeted 110 young individuals in Faisalabad, aged from 18 to 30 years. They represented a broad range of educational and socioeconomic background. It was taken from both urban and rural areas, and pilot testing was done before to provide more accuracy. So it was a structured survey that contained 19 close-ended questions regarding the perceptions of hair health, environmental awareness, and lifestyle factors, and it was validated by 2 research experts. The data was analyzed using descriptive statistics, and the results are represented through the help of charts and graphs. The most shocking result out of this was about 55.5% people had never been tested for vitamin or mineral deficiencies, which was quite concerning and alarming, while 11.8% people were not sure if they need to test for this. Then when asked whether your diet might lack essential nutrients contributing to premature graying of hair, 66.4% people agreed that yes, their diet might lack the nutrients that are essential and that might be causing premature graying of hair. And by the way, premature graying of hair means that the hair that are turning white before they are supposed to turn white before the age, before the specific age. When asked about the knowledge regarding the significance of diet on health and color of hair, about 40.4% people considered it very significant, saying that diet is very essential, while 32.1% consider it somewhat significant. So now looking back at it, people saying that diet is essential and significant, and going back, people saying that their diet might lack essential nutrients, yet there was a huger percentage of people that did not went for testing despite the fact that they knew a lot, which tells us how we are supposed to educate these peoples through our campaigns and workshops. When asked about the impact of environmental pollutants and UV rays, about 64.5% people agreed that they impact our hair and contribute to premature graying of hair. Now, here's where the fun begins. Even though 64.5% people agreed with this, when asked about the any preventive measures or lifestyle changes that can prevent or delay premature graying of hair, the huger percentage had no knowledge. 49.1% had no knowledge regarding lifestyle changes or preventive measures that may delay premature graying of hair, and 10.9% were not sure, which is a combination of 60% people not knowing what measures they should take, which also signifies the lack of proper education and guidance. When asked about the sources of information regarding hair health, the majority went to the internet to seek information, which again is accessible but not very reliable always. And even amazing thing is that about 23.9% people did not seek any information at all, despite the fact that they are faced with this problem. They did not seek any information regarding it, and only 12.8% people went to healthcare professionals. Last but not least, when asked about the primary contributors that might contribute to premature graying of hair, people considered stress as the primary contributor, which is quite all right, followed by poor diet and chemical exposure, and so on. So the conclusion of this is basically, even though people might have somewhat knowledge regarding the impact of lifestyle and environmental factors, there is an increased need to educate people and guide them properly regarding the impact of these factors. And the recommendations for this is educational workshops focused on hair health and implementing awareness campaigns targeting young adults in schools and universities. Thank you for your attention.
Thank you, Sahar. Lastly, we are honored to have Pushpak Shehzad representing her research on exploring the relationships between emotional intelligence, academic satisfaction, and professional commitment among dermal sciences students.
Assalamu alaikum, everyone. So, my research topic was exploring the relationship between emotional intelligence, academic satisfaction, and professional commitment among dermal science students. So here the objective, we will want to establish the existence of a relationship between emotional intelligence and academic satisfaction. Then we will want to establish the relationship of emotional intelligence and professional commitment, and to develop recommendations that are likely to enhance educational processes. So here is a literature gap. Current research, the relationship between emotional intelligence, academic satisfaction, and professional commitment largely focuses on healthcare or medical students. With limited attention to dermal science students, this research leaves a gap in understanding how AI influences both academic satisfaction and professional commitment within this unique client-centered field. Furthermore, this interaction among these variables remain underexplored, particularly with regard to how academic satisfaction impacts emotional intelligence and professional commitment in dermal science. Methodology. Our research was survey-based. So, according to this, a questionnaire comprising 10 concise questions, each within 2 to 4 alternative options, was prepared. The target population consisted of 100 dermal science students, including 3rd, 5th, and 7th semester. Also, our seniors are included. Factors such as emotional intelligence, academic satisfaction, as well as professional commitment were focused on during the study. Here are questions. So first one is, how often do you recognize, understand your own emotions while working on or studying in dermal science field? So 54.2% students said always, 25% students said sometimes, and 12.5% students said frequently. Next one, how well do you manage stress?
stressful situations in your academic or professional settings, in which a 28.6% students said somewhat well, 20.4% said poorly, and 22.4% said somewhat well. To what extent do you consider emotional intelligence an essential skill in your future professional practice? In which 42.9% said neutral, 16.3% said important, and 38.8% said extremely important. To what extent do you see yourself staying in dermal science field for the next 5 to 10 years? In which 44.9% students are totally unsure about their future. 30.6% students are said probably will stay. How satisfied are you with the quality of education provided in your dermal science program, in which 32.7% students are totally neutral and 28.6% said dissatisfied? How committed are you to pursuing a long-term career in the dermal science industry? So 36.7% said somewhat committed, 40.8% students said committed, and 12.2% said extremely committed. So here are results. Then conclusion, the academic satisfaction and professional commitment is positively impacted on by emotion intelligence of dermal science students as at a postgraduate level. Also, educationally oriented enhancement of EI itself will benefit student satisfaction and career. Here is the significance. It is significant as it may offer insight into factors that enhance student engagement and long-term career committed in this specialized field. These factors improve, including EI and academic satisfaction, may lead to greater professional dedication, benefiting students' career longevity and the quality of client care within the dermal science industry. Thank you.
Thank you to all our speakers for their insightful presentations. To conclude this session, I would now like to invite our esteemed session chair, Ms. Atiya, to the stage to share her closing remarks. Please join me in welcoming Ms. Atiya.
Thank you so much. I'm truly humbled by this opportunity, and it's an honor to stand in front of you. Please maintain the decorum of the conference, and I know you are being enough patient, but be more patient, okay? Okay. So I'll just quickly give comments and remarks about the presentations. Starting from Dr. Kinza Arif, it was a very interesting research. And specifically, if we talk about wound care, she just walked us through a case study, and it was very interesting. And this case study is quite of interest for people sitting here as you are going to graduate as a dermal sciences student. So this wound care case study was taken as a physician associate, right? So this basically tells you people about another opportunity, and it defines your domain more. So it was good in that regard too. Then we had Ms. Ariba's research about physical appearance of physicians and patients' perception. And skin health is most important attribute of a physician in the perception of patient when they go to visit them for their own skin concerns. So this is a quite good finding. So for people sitting here who are going to practice this thing in future, you should be taking care of, first of all, your holistic care, your skin health, and then taking care of the patient's skin health too. Then we had Miss Momina, and it was basically about melasma and the psychosocial impact. As we know that we had a broad field of psychodermatology, and every disease that is quite visible on your skin has a psychological impact too. So if you are practicing either in aesthetics, either in dermatology, you should be empathetic and sensitive enough to have that insight, to have that psychological insight, and to understand the psychosocial burden a disease is fostering over the patient. Lastly, we had Miss Hafza, and she basically discussed about selecting dermal technology degree and evaluating the motivational influences. And it was quite a interesting topic. And one part was of special interest. That was that a huge ratio of participants were motivated because they can practice aesthetics. And that is quite well, because aesthetics is quite a rewarding profession, since currently aesthetic is a $14.2 billion industry. So it is quite rewarding, and it is good that we have people who are interested in practicing this. One thing that I want to suggest is to have clear research methodology, as it was missing in most of the papers most of the research being presented here. And do notice the limitations of your research, and do work, like do tell the people or the graduates or the people who are listening to you about the future implications of the research. That was from my side, and the remaining 4 researches being presented, they will be commented by my co-chair, Dr. Kenzarif. Thank you so much.
Okay. So before commenting over the next 4 researches, I would like to say that back in 2022, I was a student at this audience, and we were lucky enough to be the part of first batch of dermal sciences, and we were completely supervised by Professor Dr. Tanzila Khalid for the research. So basically, I would say that if I am at this point, then I would advise you to basically make a strong grip on your research basics. And I have seen in my juniors who were presenting the researches over here that there is sufficiency in their methodology or in their statements like objectives and further results and conclusion sections as well. So basically, the advice is to make a clear cut points for your research and then plan a research design by clearing the gap. So the first presentation, that was that occupational dermatitis, that was presented by Miss Maida, and the title was really well, and she presented it really well. And again, she has to clear their boundaries, that occupational dermatitis further cause eczema and contact dermatitis, and plantar warts and warts does not come in that area. So you have to clear this in your section. The second presentation is from Miss Sajida, and the title was that acne among men and men coming from the urban and rural area. So that was also interesting. And again, she has to clear their objectives and methodology. And the third presentation was based on kinitis, presented by Miss Seher Fatma, and she presented it really well. Her points were actually cleared, her methodology was cleared, her results were cleared. And yes, every other student has to follow such guidelines and protocol before presenting the research. And the last one was again the Miss Khushbakt, emotional intelligence for the student of dermal sciences. And again, she presented really well, and she has to follow the proper proposal guidelines further to refine their proposal or their presentation for the future. So thank you so much from my side.
That concludes our Young Researchers session. A big thank you to all our speakers for their fantastic presentations and to the audience for your thoughtful engagement. Let's give another round of applause to our young researchers. I would now request our session chair, Ms. Attia, and co-chair, Ms. Kenzar, to come to the front and present certificates to our young researchers. I would also request Professor Tanzila Khalid to the stage to present certificates to the young researchers along with Ms. Itia and Ms. Kenza. Momina Izhar. Zara Batul. Hafsa. Sajida Asghar. Maida Razak. Sahar Fatima. Khushbakht Shehzad. One of the last presenter was me. This brings us to the end of the day one of 4th ICDS. We thank you all, our speakers. We thank you all our speakers and participants for their contributions. We request everyone to enjoy lunch and look forward to see you back for the day 2 tomorrow. Have a good meal. Allah Hafiz.